Hi, everyone. Welcome to our Targeted Therapies Forum 2023. I'm Jessica Lin. I'm a medical oncologist at the Mass General Cancer Center in Boston. And I have the sorry about that. So I have the privilege of co-chairing this forum together with Dr. Sandeep Patel from UCSD, who will be joining us very soon. We're really excited to have you here today with us on a Saturday. So as many of you know, the purpose of this meeting is to get you introduced to a range of topics that we think are highly clinically relevant in lung cancer in the realm of targeted therapies, and hopefully to get many of your questions answered throughout the sessions as well. We have a fantastic lineup of really incredible faculty speakers today. They're coming from new oncology centers and across multiple disciplines. In the morning, just to give you a roadmap for today's conference, we're going to start by reviewing some of the more general key topics. These include biomarker testing, which is the pivotal first step to getting you access to the optimal treatments. And then we'll review the role for targeted therapies in the non-metastatic disease setting. And then treatment options that can be used after targeted therapy or together with targeted therapy. Then we're going to have a brief lunch break, followed by breakout sessions. These are some of our favorite sessions for this conference, where each talk is dedicated to distinct genomic drivers and questions inherent therein. And then in the afternoon, we're going to have another general session where we have our patient research advocacy presentation, which is always a highlight of symptom management and palliative care. So before we go on to the first session, I see Dr. Patel was able to join. So Dr. Patel, would you like to briefly introduce yourself as well?
Absolutely. It's a pleasure to be joining you, Dr. Lin, as well as our wonderful faculty for today's session. I'll look forward really to an enriching session that'll help us better understand how we can best help take care of our patients from both an oncology standpoint, patient advocacy standpoint, and community engagement standpoint. And I'm really looking forward to co-chairing this with you.
Well, thank you. So without further ado, let's go ahead and get started. Our first presentation, we are very happy to have Dr. Akash Desai join us. Dr. Desai is an assistant professor of medicine at the O'Neill Cancer Center, University of Alabama, Birmingham. And he has dedicated research focused on evidence-based oncology, clinical trials, drug development, healthcare delivery, and quality of cancer care, with particular interest in thoracic oncology. He's won numerous recognitions and awards for his work. And this morning, he's here to tell us about the fundamentals and challenges today with biomarker testing in lung cancer. Dr. Desai.
Thank you so much for that kind introduction, Dr. Lin, and thank you to the organizers and our co-chairs for inviting me to speak on this topic. Before I start, can you just confirm for me that you're able to see the slides and hear me clearly?
You should be all set, Dr. Desai.
Perfect. Well, good morning, everyone, or good afternoon, good evening, wherever you are. So I'm going to start off with talking about biomarker testing, the key fundamentals and challenges in biomarker testing. Here are my disclosures. And so the topic of my talk today is biomarker testing, and I'm going to be first talking about the key biomarkers that we test for patients diagnosed with non-small cell lung cancer. Subsequently, also talking about the current standards in biomarker testing and also the barriers and challenges to biomarker testing. So the first question is, what is a biomarker? A biomarker is any gene, protein, or any other substance that can provide us more information about cancer. As you see here from this snippet, each cancer cell has a specific DNA, and the mutations or any particular proteins that are overexpressed, which are sort of cancer-causing genes or proteins, are really, what we call biomarkers from a treatment standpoint. From non-small cell lung cancer standpoint, there are a variety of biomarkers. Each person's cancer has a unique pattern of biomarkers, and knowing this is important specifically for non-small cell lung cancer because it may affect how certain cancer treatments work and may help choose the right cancer treatment for each patient. When we talk about biomarkers for non-small cell lung cancer, I like to think of two key sort of buckets of biomarkers which are important. One is essentially the immunotherapy biomarkers, which help us to select immunotherapies for our patients. Typically, we think about anti-tumor immunity through the T cells and then the tumor cells. Certain tumor cells may express a protein called PD-L1, which can actually inhibit the immune response, resulting in tumor growth. And so this protein is very important because also the immunotherapies that we have today work through this mechanism by inhibiting this inhibition of our anti-tumor immunity and subsequently sort of priming our immune system for anti-cancer properties. And the way we measure PD-L1 levels, which serves as an important biomarker, specifically when we talk about immunotherapy, is through looking at the pathology under the microscope from the tissue biopsy, and essentially through various staining techniques, trying to calculate the percentage of cells which actually express PD-L1. And compare that to the total number of tumor cells and come up with a number which is sort of ranging from 0 to 100%. The more the PD-L1 percentage, the higher the likelihood in general, the higher the likelihood for response to immunotherapy from the tumor standpoint. The other important biomarker, and you're going to hear a lot about this today, is basically the driver alterations, meaning that the alterations in a particular tumor cells which are driving cancer and tumor growth. As you know, all cells will have DNA, which is generally non-mutated. When cells acquire DNA alterations, there may be tumor formation. Now, the alterations in the DNA can occur in a variety of flavors, so to speak. It can be an activating mutation when a mutated DNA can downstream lead to an activated protein and increased activity. This is the case when we talk about non-small cell lung cancer. This is the case for KRAS G12C, EGFR, and other mutated non-small cell lung cancer tumors. The other variety of driver alteration is fusions, essentially leading to fusion of one gene to another, causing a fusion protein, which can drive tumor growth. This is what we find in ALK and ROS and RET, so some of the fusion-driven non-small cell lung cancers. And finally, there may be also gene amplifications where there's a variety of genes that may have many more copies of the gene than normal, leading to increased protein activity and uncontrolled cell growth. When we talk about non-small cell lung cancer today, there are a variety of driver mutations that we would check for, given that if there is a presence of a driver mutation identified on a non-small cell lung cancer tumor specimen, we would think that it may be more responsive to particular targeted treatment if we have one to that particular driver mutation. Here is the prevalence of driver mutations found in lung adenocarcinoma. As you see, KRAS and EGFR are sort of the most common ones, but also frequently we would find ALK, ROS1, BRAF, HER2, and others, which we will be talking about in later sessions today. And why is biomarker testing important? And it is important because that is what our progress in treatment of non-small cell lung cancer has hinged upon over the last 2 decades. This is just to sort of drive home the point. If you think about treatment algorithm for non-small cell lung cancer, a couple of decades ago, it was essentially chemotherapy for all types of non-small cell lung cancer. But today, you can see that this algorithm of treatment is sort of much, much more complex, which is driven both by actionable mutations, as I mentioned, as well as the PD-L1 percentage. And again, this slide is not meant to show the details, but really showing how the progress of treatment in non-small cell lung cancer has really hinged upon these biomarkers. So what specimens do we use for biomarker testing? The gold standard is a tissue biopsy or core needle biopsy. For early stage non-small cell lung cancer, surgical specimens, if available, serve as a very important sort of resource or specimen for biomarker testing. Sometimes we do use cytological slides and material, especially when pleural effusion and other sort of presentations where we could spin the fluid and then use the precipitated cells to sort of test for these biomarkers. A new and emerging, and I guess now sort of becoming more and more standard of care technique is called liquid biopsy. Essentially, what we have found is if we use a blood sample and spin it down with centrifuge or using high vigorous techniques using machines, what we can identify is there will be a certain section of the blood that we collect, which is known as plasma. And within the plasma may be some freely circulating DNA from the tumor cells that has been shed, which can also help us in identifying particular biomarkers of interest. So this is also known as liquid biopsy. And essentially what it is sort of taking a blood sample. In the blood vessels, you will see there are numerous cells, including our own immune cells, red blood cells, but we also may identify certain freely circulating DNA, which may belong to the tumor, especially once we identify mutations in these particular DNAs. And this is also known as circulating tumor DNA or liquid biopsy. How does it compare with tissue biopsy? There are both advantages and certain sort of drawbacks to liquid biopsy. I think the biggest advantage is that it is convenient, it is less invasive, doesn't require a tissue biopsy or a procedure which would be needed for a tissue biopsy. The other benefit is we think that it may also reflect the tumor heterogeneity, meaning that if there are multiple sites where tumor may be present, as is depicted in this diagram, if it's there in the liver, maybe in the lungs, that each tumor site may have a different sort of genetic flavor, if you will. And so it's important with liquid biopsy, we may be able to identify that tumor heterogeneity, which may not be always possible with tissue biopsy. The other benefit is that it has usually a shorter turnaround time for the genetic testing results compared to tissue biopsy. However, tissue biopsy is still gold standard, especially when we are trying to identify the nature of the tumor, the histology of the tumor, if there is any transformation to a different type of tumor from adenocarcinoma to small cell lung cancer and others. So tissue biopsy and liquid biopsy, I would think of them as more of a complementary testing rather than one replacing the other. But really, this has changed how we treat, especially in cases where getting tissue biopsy may be difficult for any particular reason in that particular case. So now I want to shift gears a little bit to talk about the current standards in biomarker testing. So the current recommendations by the NCCN guidelines, which are the national and sort of international guidelines that a lot of centers, both in the US, Canada, but also worldwide, will follow. Biomarker testing that is recommended for non-small cell lung cancer includes a whole host of essentially driver alterations like we described earlier, including the PD-L1 percentage testing to dictate therapy. And again, this is important because based specifically for the genetic alterations, based on the genetic alteration identified in a particular tumor, we will have different therapeutic options available for our patients. Again, this is just showing some of the therapies that are currently available and used in standard practice. But again, just to drive home the point that this is very specific and the biomarkers will be helping us to identify specific therapies for each of the patients that we see in our clinics. The best practices for advanced non-small cell lung cancer, essentially at diagnosis, we would definitely want molecular profiling. Reflex testing is usually preferred, so to make sure that the testing is correctly implemented. And essentially, it could be on tissue biopsy, if available, to identify standard of care therapies. When tissue biopsy is not available, as I mentioned, ctDNA, circulating tumor DNA, or liquid biopsy would be preferred, again, to identify any particular therapeutic target. If we are able to identify that even on liquid biopsy, we would generally treat with standard of care therapy based on oncogenic drivers. If we are not able to find any genetic alterations in both tissue and liquid biopsy, generally we tend to think of those cases or tumors as being non-oncogene driven and will usually have some sort of treatment with chemotherapy or immunotherapy or both. This is also important in the setting of advanced non-small cell lung cancer where the tumors have relapsed or are refractory. Again, the idea with the molecular testing, either with liquid biopsy or tissue specimen, being to identify the resistance mutations, particularly for that particular tumor. If we are able to identify a particular resistance mutation to which we may have therapies today, then those would be the standard of care therapies for those oncogene drivers. If not, then again, if tissue biopsy has not been established for the relapsed refractory cases, it is important to do that in order to identify whether there has been a change in histology or some other information that we may have missed from the liquid biopsy alone. Finally, I would like to talk a little bit about the barriers to biomarker testing. As I mentioned in the few slides earlier, that biomarker testing is sort of now the current standard of care, and every patient that we see with non-small cell lung cancer, specifically with advanced stages, but also now more and more in the earlier stage setting, needs biomarker testing. We need to identify genetic alterations. We need to identify PD-L1 status to help us make decisions for treatment. However, having said that, there are barriers to such testing. There are challenges, and unfortunately, biomarker testing is not universally applied as it should be. And so now I want to just talk about some of the barriers and challenges that we face in biomarker testing. This snippet is from an excellent paper by Sadik and colleagues that was published last year. Essentially, they studied patients with newly diagnosed advanced non-small cell lung cancer who were potentially eligible for targeted therapy, about 1,000 patients. And they found that only 356 of these patients were actually treated with targeted therapy. So really, there are a lot of practice gaps that have been identified, which are prohibiting us or preventing us from truly applying precision medicine or precision oncology as we would like. I think some of the biggest barriers here is actually ordering and obtaining biomarker testing. As you see, about 18% of patients did not have this as standard of care in this particular study. And the other issue or barrier is the treatment decision making, and actually for the patients where we've identified genetic drivers or immunotherapy-based biomarkers, to actually apply those results in treatment decision-making. Again, here you see about 30% of patients did not receive treatments as per their biomarker testing. And some of the issues in terms of ordering the test, physicians not ordering the testing, lack of awareness of the current guidelines for non-small cell lung cancer testing, as well as insurance challenges are what truly prohibit ordering of the biomarker test. And in terms of treatment decision-making, again, targeted treatments not being selected despite positive test result or report indicating no therapy or alternative were the major reasons for why this practice gaps occurred. There's more data and evidence showing that the adoption of biomarker testing is substandard. This is a sort of slightly older study now, a retrospective study from 2016 to 2020 among the community oncology sites, again showing there is inadequate testing in community oncology setting. On this right panel here, if we look at the numbers, here this particular study only included the 5 of the biomarkers that we discussed. And again, among these 5, if you look at the patients, the number of patients who actually had biomarkers tested before initiation of first line, really sort of falling between 25 to 55%. And again, this really should be 100% is what the aim is and the goal is. And again, of these patients, biomarker-directed treatment, as you see here, also varied widely among the different biomarkers that were identified, and again, identifying the same practice gap of actually applying the results of our testing paradigm. Solutions to this may be integrating these testing as reminders in our electronic medical records. This has been studied. There is this EMR-based nudge intervention workflow, which was developed by our colleagues at University of Pennsylvania, where every time the care team saw a patient who had newly diagnosed treatment-naive non-small cell lung cancer, there would be a trigger to the provider team to to really identify whether a plasma-based next-generation sequencing biomarker testing assay was indicated, and if it was indicated, was it ordered, or it would help an auto-generated NGS order, which actually did increase the amount of biomarker testing. On the right panel here, they look, are the results from this study. They looked at 526 patients, 381 in the pre-intervention and 145 in the post-intervention cohort. And essentially with this sort of nudge, as well as the email-based reflex alert program workflows, they were able to post-intervention, there was a significant increase in ordering of tissue as well as plasma next-generation sequencing, comprehensive next-generation sequencing, as well as the next-generation sequencing prior to the first-line therapy in the post-intervention setting. So this potentially could serve as a solution to make sure that we are ordering biomarker testing when it is truly indicated for our patients, and hopefully we're not missing as many as we saw in some of the earlier studies. The other issue has been insurance coverage. There was a survey by a marketing sort of communications company showing academic medical centers, community and commercial payers, and really trying to identify barriers to NGS as a top barrier to next generation sequencing testing. In March of 2018, Medicare announced coverage of next-generation sequencing for patients with cancer as part of their national coverage determination. This was for all patients with cancer, not just specifically for non-small cell lung cancer. But I think some of these efforts might be needed in order to make sure that cost doesn't become a barrier to biomarker testing. So potentially national coverage determination and other such advocacy, and other such efforts through advocacy may be potentially a solution to, the cost barrier for biomarker testing. There was this study which was conducted in 2021, almost 2 to 3 years after the NCD was announced. And it did show that the percentage of patients receiving next generation sequencing testing within 60 days here for non-small cell lung cancer patients, this is pre the coverage determination announcement, and post coverage determination announcement, we do see there is an increase. It's still at 45%. Again, we need it to be higher, but this potentially could be one of the solutions to, again, broadening access to testing. The other interesting thing that this particular study demonstrated was, with the coverage determination being just for Medicare, there was quite a significant increase in NGS testing for patients who have Medicare-based insurance, and there were increase in NGS tests even for patients with commercial insurance, but not so much for patients who were in state Medicaid programs. So again, this sort of Medicare-based policy or national policy may be helpful in general, but still may widen gaps and disparities based on the patient's insurance type. So again, this may not occur equally across all insurance types. And again, further efforts beyond coverage policies are needed to ensure equitable access to the benefits of precision medicine and eliminating cost as a barrier to biomarker testing. And finally, as we discussed, one of the final practice gaps is actual administration of biomarker-driven therapy. Another study, again, a few years ago now, showed that only a minority of patients received biomarker-driven treatment, even when driver mutation was detected. Now, granted, this is a few years ago, but 45% is really a less of a number than what we would like to see in this particular case. This study also identified a lot of patients received immunotherapy, often prescribed instead of targeted therapy, even when the molecular results were available. And I suspect some of this may be because the genetic testing and driver alteration testing takes quite a few weeks, and generally it is a very uncomfortable time both for the patient as well as for the provider to just wait for the genetic testing results. But I think as we've done this more and more, I think both the providers and patients have felt more comfortable waiting for that, because as you see, and you will see during the rest of the program today, that this is really, really important. Because if we are able to identify a genetic driver and target that genetic driver, we we have seen much more improved outcomes compared to treating everyone the same way as we did in the 90s. Some of the primary reasons for failing to act on positive predictive biomarker results, this, again, the study from 2022 that I showed you with the practice gaps identified lack of awareness of targeted treatment as one of the causes of actually not administering these treatments to patients. Social determinants of health access and disparities, as well as again cost of therapies and insurance coverage being another concern and barrier to administration of therapy. So again, the access and affordability are very key issues in biomarker-driven therapy. We are able to identify the biomarkers that are present, but do we have access to the treatments for our patients? This is a study which was recently published looking at EGFR and ALK TKIs administration for patients with non-small cell lung cancer in state Medicaid programs. And again, here it's showing about 30 out of the 33 to 34 states that the author studied in this paper actually had lower than expected range of patients being treated with EGFR and ALK TKIs. So again, access is a big issue. It should not be a barrier. The state that you live in should not be determining the type of treatment you get for your non-small cell lung cancer. So really this needs to change. And again, more advocacy is needed in this particular area. Affordability is another important issue. Now, a couple of years ago, our team looked at the pricing for EGFR inhibitors and ALK inhibitors and how over the last few years, the prices had increased, not just increased, but increased over the consumer price index over those years. And again, making affordability and out-of-pocket expenses an important issue. And I think it's very important for all of us to realize that for patients who cannot afford therapy, regardless of the tumor mutational or tumor PD-L1 status, the tumor response rate is going to be 0% if we are not able to administer these therapies to our patients. And so finally, I think I would like to summarize with some potential solutions. As I mentioned, testing, awareness of testing, improving our assays, improving our coverage for liquid biopsy and other infrastructure capabilities like we saw, implementing this to make sure that we are ordering appropriate testing for our patients, expanding the coverage and advocating for patient support systems, out-of-pocket estimation, global expansion of the coverage for biomarker testing, as well as finally administering treatments based on biomarker testing and advocating for coverage of therapies which improve outcomes for our patients is needed. And that is something both the patients and the providers should be teaming up to do. And so with that, I would like to conclude and thank you so much for your attention today.
Great. Thank you so much, Dr. Desai, for a wonderful talk, and there'll be an opportunity for questions, but please keep them coming in the chat. It's been highly interactive so far, and we're looking forward to a nice interaction with folks during some of the dedicated sessions. And so next, it's my privilege and honor to be introducing Dr. Joshua Royce. He's a thoracic medical oncologist at Georgetown University, assistant professor at Georgetown University Medical Center, where he specializes in lung cancer, mesothelioma and thymoma, and he has particular scientific interest in resistance mechanisms. He received the YA from the Conquer Cancer Foundation from ASCO 2019 for his research, and he will be discussing non-metastatic disease and targeted therapies.
All right, thank you, Dr. Patel. Let me just share my screen here. Okay, sorry. All right, can we see and hear me okay? Are we good?
Yes.
Perfect, thank you. Thanks for the audio. I can't see the platform anymore. So my name is Dr. Joshua Royce. I'm a thoracic medical oncologist at Georgetown University and assistant professor of medicine. And I'm privileged to be here today to speak on non-metastatic disease and targeted therapies, a very rapidly evolving space. These are my disclosures. I want to begin by discussing kind of a visual glossary of terms. I might be throwing in some medicalese accidentally, and I just want to describe some terms and what they mean in the context of targeted therapies in non-metastatic disease. So when we look at someone who's potentially can get surgery for what we say a resectable non-small cell lung cancer, if we give treatment before surgery, medical treatments, that's called neoadjuvant. That means giving chemotherapy, immunotherapy, targeted therapy before surgery. If we give these treatments after surgery, we refer to that as adjuvant, giving medical therapies after surgery. And then more recently, as we have more evolving trials, we've kind of referred to lumping treatment both before and after surgery as kind of a perioperative technique. So that's one thing I wanted to get across. The second has to do with outcomes and disease-free survival and overall survival. You might hear us throwing these terms around occasionally. And so let's take, for example, a 10-patient clinical trial. And a year later, you look at follow-up of a 10-patient trial in patients who have a curable lung cancer. Of these 10 patients, 5 are alive and disease-free. 3 are alive, but unfortunately have experienced recurrence of their cancer, and 2 unfortunately have passed. At this 1-year time point, the disease-free survival, meaning percentage of patients who are alive and without recurrence of their cancer, would be 50%. However, the 1-year survival rate would actually be 80% because while 5 patients are alive and disease-free, there are actually 3 who are alive and have experienced cancer recurrence. So just an explanation for some terms that we utilize in this disease setting. So where were we in treatment status for patients? Up until very recently, the only thing we offered patients with resectable lung cancer was chemotherapy. And you could see the long-term survival outcomes were really abysmal for this stage of disease. For stage 1B to 3B, survival rates of 24 to 73% at 5 years. And really the benefit of chemotherapy was limited to about 5% at 5 years, whether it was given before surgery, neoadjuvant, or after surgery, adjuvant. You could see on these curves, I know these slides appear a little small, so definitely download these, look at these more closely, but I'll try to discuss them in detail. So the top line of both of these curves is giving chemo, and the bottom line is no chemo. And you can see, while there's a benefit, it is not as high as we'd like to see. So how has this field changed? And really the big trial here was the phase 3 Adora trial. This trial randomized patients with completely resected stage 1B to 3A EGFR mutated lung cancer to osimertanib, our frontline targeted therapy standard for EGFR mutated lung cancer, or placebo. And I'm going to walk you through the study design here. So on the left are the inclusion criteria. So this study included patients with, again, resected stage 1B to 3A non-small cell lung cancer, and this utilized a slightly older staging system. So roughly translated, this correlates mostly with stage 2 and 3A patients with today's staging, though it did include some stage 1. These patients had to have an activating EGFR mutation. So our classic EGFR activating mutations, exon 19 deletion and exon 21 L858R mutation. And patients were randomized, patients were then stratified by disease stage, by the type of EGFR mutation, by race, and then randomized 1-to-1 to receive 3 years of osimertanib or placebo. The primary endpoint, so how the study was designed to look at a clinical endpoint, was to look at disease-free survival, as I said earlier, time to cancer recurrence in the higher stage 2 and 3A patients, but key secondary endpoints did include overall survival. So as this figure shows, the disease-free survival was remarkably positive with this trial. You could see out 4 years from the beginning of adjuvant targeted therapy, an incredible disease-free survival benefit with 70% of patients who received Tagrisso at the stage 2 and 3A patients alive and disease-free at 4 years compared to 29% who received placebo. And this roughly translated to a 77% disease-free survival benefit for osimertanib over placebo. Again, this is in the primary population that was looked at, the stage 2 and 3A patients. And when looking at all patients, so including the 1B patients, a very similar, very impressive outcomes, again, with a 73% disease-free survival advantage. Now, because of this data, in 2020, the FDA actually approved osimertanib for therapy after surgery Interestingly enough, for all patients with EGFR mutated lung cancer with these alterations in exon 19 deletion and 21L858R mutation. So irrespective of disease stage, and what this really speaks toward is that we should really be considering next generation sequencing for all patients with a resected non-small cell lung cancer to evaluate for an EGFR mutation. What are some other key outcomes here? So importantly, osimertinib is effective in the brain, and so can shrink down brain metastases in patients who have advanced disease, and also can help to prevent metastases from occurring in the brain in this setting. So what this figure shows is that what we call central nervous system disease-free survival. So the percentage of patients who are alive and without cancer occurring in the brain, and you could see at 4 years for those who received osimertinib, that percentage was 90% compared to 75% who received placebo. Now, no therapy is without side effects. We view this as primarily a tolerable safety profile. And for those on this presentation who know these side effects, who've experienced them, more commonly was seen diarrhea, nail changes, dry skin, itching. However, just to break down, what low grade does not mean that this is something that doesn't affect quality of life. And for example, a grade 1 diarrhea means increase in stools up to 4 times or just below 4 times per day above your baseline. Grade 2 means 4 to 6 times above baseline. So while we refer to these as low grade and we don't code these as serious, obviously these are side effects that can affect one's quality of life. Now, an important question and point is, do the chances of cancer coming back increase after stopping osimertinib? Now, these are the disease-free survival curves broken down by stage. And what I mark here with this red line is the duration of treatment. Remember, osimertinib was given for 3 years. And the slope of these curves indicate patients who are experiencing a recurrence. And so as each patient experiences a recurrence, that number drops from that 1 at the top of the curve all the way down. And you could see here that particularly for the stage 2 and 3A patients, after osimertinib was stopped, that slope of the curve becomes a lot more steep, indicating a higher rate of cancer recurrences in those who had received Tagrisso. And so for us in the lung cancer community, we were very curious to see why this therapy obviously does benefit disease-free survival. If recurrences increase, will we see a true overall survival benefit for our patients? And luckily enough, earlier this year at ASCO, we did see an overall survival benefit result from this study. And at 5 years, in the primary population of stage 2 and 3A patients, 85% of patients were alive who received Tagrisso compared to 73% who received placebo, translating roughly into a 51% overall survival benefit for osimertinib versus placebo. And just a side note, when I talk about this benefit, this refers to a hazard ratio, which is statistically how we look at benefit for a lot of these therapies. In the total population, including stage 1B, also a similar, very exciting survival benefit for osimertinib or Tagrisso, the trade name, compared to placebo. Now, when broken down by disease stage, you can see here the benefit was most pronounced in those with stage 3A disease, where we saw a nearly 20% numerical increase in survival at 5 years for osimertinib compared to placebo, but there was clear benefit observed across disease stage that was included in this study. So what are some important points and questions for the Adora trial? So number 1, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer. Again, this was by the earlier staging system, but based off the FDA approval, osimertinib can be given for all patients with an EGFR mutated resected non-small cell lung cancer. Importantly, in my opinion, osimertinib does not replace chemotherapy when indicated. This is typically stage 2 and 3 disease because we do know there is a survival benefit there. I think one question that we're still grappling with are more patients truly cured with osimertinib after surgery, or does just a very prolonged delay in recurrences lead to the survival benefit that we've seen? In a practical sense, I don't think it really matters because we know there's an overwhelming clinical benefit and this therapy clearly helps patients and is indicated, but it's more of an academic question here. To that point, how long should patients take osimertinib after surgery? Is 3 years long enough, or should we continue longer? And on the flip side, are there some patients who are cured with just surgery and don't need osimertinib? And I think lastly, and this is an important point, is can this approach be used for patients with other driver mutations, such as ALK, RET, ROS1? And I think there are key factors here. Number one, you must know that understand there's a lack of data here. So everything we would do in this scenario is extrapolating from Adora. But there are key attributes that drugs, I think, need to have to be considered here. And that includes very effective therapies that have a tolerable safety profile, or one could take this for 3+ years. And the drugs must have an ability to get into the brain. And as Dr. Desai mentioned earlier, financial toxicity and insurance coverage, very important here as well, especially since strictly speaking, this is not an indication that's yet FDA approved. So what are some ongoing trials addressing osimertinib, some of these questions? So for duration of therapy, there's the phase 2 Target trial, which is looking at 5 years of osimertinib for stage 2 and 3B patients. And on the right is the phase 3 Adora 2 trial, which is looking at osimertinib in earlier stage 1A, 2, and A3 patients. A trial that we hope to see results for soon in the ALK space is the phase 3 ALINA trial, which is looking at patients with resected stage 1B to 3A non-small cell lung cancer randomized to 2 years of alectinib, which is one of our frontline targeted therapies for ALK fusion positive disease, versus chemotherapy. Transitioning now to giving targeted therapies before surgery, what we call neoadjuvant. And I will say there is limited data for our more modern targeted therapies in this space, but we are seeing some early data from trials for osimertinib preceding surgery in EGFR mutated lung cancer. And this is somewhat of a complex table and perhaps made even more complex by the size on your screen. But a few key points here. Number one, there's a high percentage of imaging responses with lymph node response and actually downstaging of the tumor, which translates into a high rate of surgical resection and complete tumor removal. So what this indicates is osimertinib can effectively shrink tumors with high rates of complete surgery after giving osimertinib, at least in these early studies. However, when we look at pathologic response, we see something interesting. So MPR, that means major pathologic response, which means that when the surgeon goes to cut out the tumor, there's less than or equal to 10% tumor in the specimen that's been removed. PCR, pathologic complete response, means when the surgeon goes to cut out the tumor, there's actually under the microscope no tumor left after the treatment that was given. And you could see that these rates are quite low with osimertinib. And what that means, while these are small early studies, is that osimertinib alone is unlikely to fully eradicate and cure patients with resectable lung cancer, suggesting that surgery and perhaps additional adjuvant therapy is needed in this case. So there are ongoing phase 3 studies looking at perioperative, so before and after targeted therapy. This is the phase 3 Adora Trial, which is looking at patients with resectable stage 2 to 3B EGFR mutated lung cancer, randomizing 1:1:1 to chemo, or chemo plus osimertinib, or osimertinib alone, followed by surgery, and then optimal adjuvant, meaning medical therapies after surgery, including up to 3 years of osimertinib. This is a basket trial, or I should say umbrella trial, that includes multiple different cohorts of driver mutations with appropriate targeted therapy being administered before surgery, and then a similar design of adjuvant, meaning after surgery, medical therapy with targeted therapy included. And this is not all inclusive, but these are some other trials of RET, MET, KRAS that are designed similarly to be given both before and after surgery. So you'll notice I have not mentioned immunotherapy at all thus far. So what about immunotherapy in patients with driver mutations who potentially can be cured with surgery? Importantly, in patients with driver mutations with stage 4 disease, immunotherapy by itself is largely ineffective. We actually have 2 large phase 3 trials of EGFR mutated lung cancer that showed that adding immunotherapy to chemotherapy had no demonstrated clinical benefit compared to chemotherapy alone. Now, you might ask, well, what's the harm of at least trying immunotherapy, seeing it benefits a lot of people? But we do know that giving targeted therapy after immunotherapy can lead to risk for serious toxicity. So this is not benign and can get into a tricky situation if one needs to start these targeted agents. An additional important point is that most immunotherapy trials for patients with resectable lung cancer excluded patients with driver mutations. And those that included these patients were not designed to evaluate the effectiveness of immunotherapy in patients with driver mutations. So it's my opinion that immunotherapy should not be considered on a routine basis for most patients with driver mutations, with some notable exceptions, including KRAS and some others who have surgically resectable lung cancer. So some additional considerations and questions for targeted therapy before surgery. I think the likely outcome here is that we're going to see appropriate targeted therapy leading to effective tumor shrinkage, which can hopefully improve the ability for patients to get a complete tumor removal with their surgery and perhaps less complex surgeries. So will this change practice? Will this lead to FDA approval? I think, we need to see. Targeted therapy before surgery is unlikely to replace the need for continuation of targeted therapy after surgery. Due to the pathologic outcomes that we've seen, I think that targeted therapy will need to be continued after surgery as well. If results of Adora are positive, so giving targeted therapy before surgery, will we extrapolate this approach with other driver mutations? I think that remains to be seen. How will chemotherapy be sequenced? Is there still a role for stage 2 and 3? I think there likely is, but we need to see that. And then, as I mentioned before, immunotherapy-based approaches in the perioperative setting should not be pursued for most patients, though mutation subtype, smoking history, other factors may play a role here. So in the remaining moments, I want to touch briefly on locally advanced unresectable lung cancer with a driver mutation. So our standard of care for patients with locally advanced lung cancer who can't get surgery is to give curative intent chemotherapy with radiation, followed by immunotherapy. That was shown in the large phase 3 Pacific trial that randomized patients after chemoradiation to durvalumab immunotherapy or placebo. And these are the outcomes from that trial. And I won't go into the detail, but the blue lines were the immunotherapy, and you could see both in time to cancer coming back, which is progression-free survival, I should say time to cancer growing, progression-free survival, or overall survival, we saw improvement with immunotherapy. But importantly, the study did not assess driver mutation status of patients. And in the lung cancer community, I think we were all a little skeptical of the immunotherapy benefit in this approach. Now, there is limited data here. This is a subgroup analysis from this trial of EGFR mutated patients, and I'm sure it's hard to see, but only 24 patients with EGFR mutations received durvalumab and 11 received placebo. But with that being said, there was not a clear sign of clinical benefit with the addition of durvalumab for progression-free or overall survival. So there are several trials ongoing. This is the phase 3 LAURA study that looks at giving osimertinib or placebo after definitive chemoradiation for patients with stage 3 unresectable lung cancer. And then this is a platform trial that's looking at a few other driver mutation populations of giving appropriate targeted agent versus immunotherapy for a stage 3 unresectable lung cancer. So a few key points and questions from this disease stage. Number one, I do suspect that LAURA and other trials in this setting will be positive. But in the absence of data, should we extrapolate results from Adora, so giving osimertinib after surgery, and consider targeted therapy after chemoradiotherapy now? I, for one, am starting to look at this with some population of patients, but it's an important question. And then what treatment duration is most appropriate? Is it 3 years? Is it indefinite? And as I've alluded to earlier, what subgroups are most appropriate for this approach? And again, that requires an effective therapy with good brain penetration, tolerable safety profile, and importantly, something that can be financially covered with insurance. So importantly, what can you do? Number one, ask and advocate for next generation sequencing. You won't be able to have these discussions and get the most directed therapy without knowing the molecular status of the cancer. Number two, talk to your medical oncologist about the relative pros and cons of targeted therapy, because most of the settings that I've talked about are not FDA approved indications, and it's important to have these discussions. Engage patient advocacy groups to learn more about these therapies and connect with patients who are taking them, perhaps in the same setting that you're considering. And plan redundancy, please ask and advocate for next generation sequencing. If you have a localized cancer, you might see a lung doctor and then a surgeon, but never be referred to a medical oncologist. And so it's important to ask to see a medical oncologist, ask for next generation sequencing so that you can really determine the biologic nature of the cancer. So in conclusion, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer, and is approved for all patients with resected lung cancer with an EGFR exon 19 deletion or 21 L858R mutation. Trials of targeted therapy are ongoing for patients with surgery or patients after surgery, before surgery, and after curative intent chemoradiotherapy. However, can we already now extrapolate our approach of giving osimertinib after surgery to those with other types of driver mutations and to those after curative intent with chemoradiotherapy? I think the answer to this is yes, and we're already starting to do this for some types of subgroups of driver mutations. There are many important questions that remain, however, including what is the appropriate duration of treatment, who truly needs targeted therapy, who is cured by surgery with or without chemo. As I alluded to earlier, immunotherapy is not likely to be beneficial for most patients in this setting. And then I cannot stress the importance enough. Next generation sequencing to assess for driver mutations is critically important to determine the most appropriate treatment approach. And so with that, I thank you for your attention. I look forward to discussions. I include my email here. Don't hesitate to reach out to me with any questions you might have. Happy to help. Thank you.
Thank you so much. Terrific discussion, Dr. Royce. That was just completely on point. Thank you so much. And I'm sure there will be lots of questions that we can go over in the Q&A session. Now, everyone, after lunch, we are going to have several breakout sessions that are dedicated to targeted therapy for the respective genomic subsets of lung cancer. For the very next session, we thought it would be helpful to take a step back and review how we consider adding to targeted therapy, or perhaps what are the options after targeted therapies have been tried. And so for this session, we're really fortunate to have Dr. Punith Iyengar join us as the faculty speaker. Dr. Iyengar is currently an attending physician and director of the metastatic service in the Department of Radiation Oncology at the Sloan Kettering Cancer Center. He has clinical research that's focused on developing synergy between local therapy and systemic therapy for advanced lung cancer. So I'm sure he has a lot of insights to offer for us on today's topic. Dr. Iyengar.
Thank you very much, Dr. Lin. I really appreciate it. Let me share my screen. Let's see here. And okay, share. And then, and I hope everyone can see that. So at the end of the day, Akash and Joshua really set the stage for what we're going to talk about now. And it's really maximizing the benefit of TKIs and maximizing their impact with respect to durability of outcomes. And how do we really think about doing that? We can think about doing that multiple ways. One is adding local therapy, which is going to be the bulk of what I'm going to talk about. I think it's an exciting new area, an opportunity to do something we've not really done in the metastatic state. And then the idea of optimizing systemic therapy, I'll put that at the very end because there are many medical oncologists and multidisciplinary team members who are working on that approach. So, as we know, we all know this is not anything new to this audience. There are 239,000 expected cases of non-small cell lung cancer in 2023, or lung cancer in general, as per the ACS. Majority of the non-small cell lung cancer patients are going to have stage 4 disease. And so we have multiple FDA-approved regimens that are supporting that approach. And the real question, in my mind, as part of the multidisciplinary team, is we have realized an incredible improvement in survival outcomes associated with this new agents, whether it's immunotherapy, whether it's targeted therapy, and it's associated, and I will not downplay side effects associated with these therapies, but significantly improved toxicity profiles with respect to cytotoxics. But we want, as a team of patients and physicians, we want to optimize durability of outcomes for a majority of our patients. And so that's where, the question becomes, when a TKI is working in a majority of sites, but there are maybe a few sites of disease that are progressing, should it be our instinct to switch therapies like it has been historically to a second-line systemic therapy? Or should we try to do something different to try to optimize the continued use of that TKI? And so, as all of you know, in this audience, biology is really what's driving our outcomes for advanced non-small cell lung cancer. Whether it's patients with EGFR, ALK, KRAS, RET, MET, ROS mutations, we have now developed a plethora of optimized treatment approaches, at least in the first line setting, to navigate these different disease entities. But as radiation oncologists started thinking about these problems in the 1990s, Wetzelbaum and Hellman, who were at the University of Chicago, started wondering, is there a way to add local therapy in the form of radiation and or surgery to optimize the durability of our outcomes and to help synergize with systemic therapy to improve survival outcomes? And so that's what this idea of limited versus widely metastatic disease and the idea of oligometastatic disease, that's how it gained hold. And so, as all of you know, disease evolves. It starts as a primary cancer. It evolves in some patients to development of metastatic disease. But Hellman and Wexelbaum thought that maybe it evolves to a position where there are only a few lesions that and few sites that the primary lesions metastasize through to. And eventually, due to progression of disease, failure of therapy, a combination of both, it goes more widely. And what Hellman and Wexelbaum and a number of others thought was that maybe we could leverage that intermediate state to optimize disease control and durability of systemic therapy responses. And so again, as I said, biology drives survival. We need to keep that in the back of our mind as we think about the future of the synergy of potential local and systemic therapies. So again, what is the rationale for considering using local therapy for metastatic disease beyond palliation? I think the improvement of systemic therapies, the idea that even though we have improvement in systemic therapies, they're still not perfect and often do not stand alone. The idea that modern diagnostic tools, including imaging, can help identify patients at earlier stages of metastatic disease, and hopefully with screening mechanisms help with that process as well. So the idea is there a potentially chronic or curable subset? More data to support the use of local therapy. If we look at patterns of failure, what group in Colorado and others have shown is that the original sites of disease that patients have are usually the first sites in which failures occur and progression of disease occurs. So the question was, why not consider employing local therapy if we know more likely than not where the first sites of failure are going to be in the body? And this is what, again, led to this kind of innovative hypothesis that Hellman and Wexelbaum developed in the 1990s. But we actually have now significant data to suggest that this may be actually helpful. One is we have to look and congratulate our surgical oncology colleagues who, for years and decades, were aggressive with metastatic sarcoma and colorectal cancer that went to the lungs, for instance, or the liver, in resecting those aggressively and still treating patients with a very much a curative approach in the stage 4 setting. The same was done with metastatic non-small cell lung cancer that had isolated adrenal lesions. And then, of course, neurosurgeons have historically been aggressive when necessary for limited metastatic disease that's gone intracranially. And all of those studies suggested actually a benefit in survival, not just a benefit in symptoms or progression-free survival, even some suggested overall survival. So again, the ideas for using local therapy in metastatic settings or limited metastatic settings. Chemo-IO studies don't really describe patterns of failure, but in general, failures occur in first sites of disease, and responses last but don't last forever. And so that's kind of the direction that we started taking to think about this as a field in radiation oncology. It happened to coincide with the evolution of SBRT, and I hope a lot of you have heard about SBRT. It is a highly conformal, image-guided way of using radiation to treat specific depots of disease in the body. It's non-surgical. We can literally use SBRT to treat sites from the top of the head to the bottom. And quite honestly, SBRT has, if used appropriately, limited toxicity, and it was more or less perfectly suited to treat metastatic disease because, as I said, there was limited anatomic constraints as long as we followed, appropriate protocols. So I'm going to talk about a few scenarios where local therapy has been used in non-small cell lung cancer for the management of oligometastatic disease. And I'm going to really focus on the first two topics, consolidation and oligoprogression. And how do I define consolidation? I view consolidation, and the field views consolidation, as patients who have metastatic disease. They receive some frontline systemic therapy, in your case TKIs, or targeted therapy of some form or another, or immunotherapy for other patient populations in non-small cell, or in small percentages now cytotoxic chemotherapy. After about 3 months, we re-image the patients to see if they have limited sites of metastatic disease that would make them amenable to radiation. Then those patients would receive radiation or undergo surgery to those metastatic sites, as well as treatment of the primary, and the patients would move on to continue systemic therapy. And the idea was, could we improve survival outcomes, progression-free survival and overall survival, by adding radiation at that point in time after they've received some form of induction systemic therapy. So this is a complicated slide. I think you guys will all get access to this slide set, but there were multiple studies that asked this very question. When we add radiation in a randomized fashion, can we improve progression-free survival? And the three arrows allude to three studies that included non-small cell lung cancer patients where use of radiation improved progression-free survival significantly, in many ways, threefold increases in PFS. And then in two of the studies, the top one and the bottom one, Gomez and Palma, they also showed an overall survival benefit with the addition of that local therapy. Now, the first study, the Gomez study, did include patients with targetable mutations. It was about, for instance, EGFR was about 12% of patients. And even in the targeted therapy group, they saw a benefit with the use of local therapy. So this gave us some signal, early phase studies, not very large, that the use of radiation in a randomized fashion could actually help with not just progression-free survival, but overall survival. So there's a very interesting and exciting set of studies supporting our field's hypotheses. None of these studies, of course, incorporated immunotherapy. They were preceding that era. So as we started thinking about immunotherapy, and I'm just going to get to this explanation as a paradigm of understanding how we've started moving in the same directions with targeted therapy, specific targetable disease. Immunotherapy has shown some benefit in some early studies, but then there have been other studies, like this other one that came out of the NCI, where there was not a significant benefit. So the jury is going to be out. I'm running this trial, LU002, which is asking this very specific question. In the setting of what we call consolidation, does the addition of radiation help survival? And hopefully we'll know that the interim analysis will be done in a few weeks, which will give us a go, no go to the phase 3 portion. But in parallel, there have been a number of studies that are looking at local therapy in the setting of disease that's targetable. And so at UT Southwestern, we did a study that was with the City of Hope. It hasn't been published yet, but in a single arm phase 2 study, we finished enrollment and we're doing the analysis. Patients that had EGFR mutated disease started with osimertanib, and then after about 8 weeks of therapy, as long as they had limited number of sites of disease, we gave radiation to all of those sites, and then the patients continued on osimertanib. And this study, the key point of this study was to understand whether there would be like a benefit in terms of progression-free survival progression-free survival and overall survival compared to historical outcomes in patients who receive osimertanib alone. We did a parallel sister study with ALK rearranged disease, where we combined, in this case, ceritinib again, but this case it was a phase 2 trial where we had patients that had ALK naive disease, and then patients that also had ALK resistant disease, inhibitor resistant disease, and we basically re-imaged and then did radiation again to all of these patients and all of their disease. And again, the idea is to see in the setting of treatment naive patients or patients who receive therapy, whether the radiation will help with progression-free survival. Again, we finished enrollment on this study and hope to get some information further. There have been 2 other studies out of MD Anderson looking at a similar concept. Start with the systemic therapy in the form of osimertanib, in the top study. It's a randomized phase 2 study, and they're still, I think they've completed enrollment, and they're going to wait about a year and a half before they for a follow-up to look and see whether local therapy helps. The idea is to synergize with the systemic therapy and improving survival outcomes. And they also have a phase 1 study looking at local therapy in the setting of patients receiving brigatinib. Now, some people will ask, what about doing this upfront? What about adding radiation upfront in patients that have oligometastatic disease? Can we add radiation and see if in EGFR mutated patients, for instance, this study was published in the JNCI, and see if these patients can actually, do well. And this study was really exciting. It was published in in 2022, reported out in 2023. But the idea was that the addition of radiation upfront to metastatic disease and to the primary improved progression-free survival and overall survival. Why are we not using this for every patient now? Well, part of the reason is that if you look at the first 9 to 12 months of the study, and you're looking at these Kaplan-Meier curves, you see a very flat line. That was a little bit concerning to a number of us in the field, in that we expect patients who receive TKIs to certainly have very significant, durable progression-free survival. But we would expect some significant events within the first year, and there really were not that many in this trial. So we are waiting for larger studies to be conducted and completed before I think we change our practice patterns with this patient population. Now I'm going to switch gears real quick to talk about oligoprogression. What is oligoprogression? It's patients who have received frontline therapy, and then their disease progresses. But their disease progresses only in a limited number of sites. And some people, and so at the end of the day, as we said, all patients with TKIs will eventually progress. Hopefully it's from a long time out. Some will have oligoprogression, meaning to a few sites of disease. And so the question was, with this group that was published back in 2012, is that they decided to radiate or consider radiation for those patients that had oligoprogressive disease. And so their hypothesis was that the patients that had progressive disease in a limited fashion gets radiation, that they could have an improved progression-free survival. And that was kind of what they showed in this study. So again, some evidence to suggest maybe not in the upfront setting or the consolidation setting, but after you've progressed on a frontline therapy, but in an progressive condition, there still may be benefits from local therapy. We also took this kind of role. Can we add SBRT to patients that have progressed on frontline systemic therapy, in this case, erlotinib? So we actually treated patients who had failed erlotinib, who had 6 or fewer discrete lesions with SBRT, continued the patients on erlotinib to see if it controlled disease elsewhere. And these are just some of the characteristics. But at the end of the day, we found a PFS and an OS that was quite good compared to historical patients that were just on erlotinib, who had failed 1, 2, or even 3 lines of therapy. So again, it gives us hope that these patients who may get local therapy in a selected patient population will do really well. And it actually changed the patterns of failure. The addition of radiation stopped patients from failing first in original sites of disease. What it did was it delayed failures, and when failures occurred, it was in new sites of disease, not the original sites of disease. And so that's really what we wanted to see. Unfortunately, very interestingly enough, this study preceded the era of widespread mutational testing. None of the patients that we tested had EGFR mutations. So in many ways, and then back then, remember, EGFR inhibitors were thought to be of help in the wild type EGFR setting. And now, of course, we know that that's not to be the case. But in any event, this study suggested that SBRT, again, in an oligoprogressive condition, could be helpful. So there are some randomized studies. This one is Stop Non-Small Cell Lung Cancer for Oligoprogressive Disease. That includes Targeted Therapies. This is HALT. It's in Europe. They are finished accrual, and we look forward to seeing the results of both of those studies, these 2 randomized studies. And so at Memorial Sloan Kettering, they recently completed a study using, again, a radiation in an oligoprogressive state to look to see if there was a benefit in the use of local therapy. And again, the idea is that we shrink the disease, but some patients will start failing and progressing in original sites of disease. Can we use local therapy? So this study included patients that had EGFR mutations that were on osimertanive. And they basically either received radiation to the local disease that progressed or did not receive radiation. And as you can see here, the patients that received radiation, the curve in red, they had a significant improvement in progression-free survival compared to the patients that did not receive radiation to their oligoprogressive disease. So again, a very interesting and positive signal in this space. But with the last few minutes, I'm going to basically say that we haven't done enough. We haven't done enough to understand when to use local therapy to better personalize our treatments for all of you. And the reason is because we failed to predict disease trajectories. All of our previous studies were basically saying we're defining oligoprogressive disease or 3 or 5 or fewer lesions. We're describing oligometastatic disease as 3 or 5 or fewer lesions. That number is a snapshot in time. It is not giving us a dynamic understanding of disease trajectories. And so I will call all of us to start thinking about how, as a field, as patients, to push for the idea that we need to do larger scale studies, real world analyses to better understand what the true trajectory of metastatic disease is in the setting of therapy and across time. Only then will we be able to learn whether local therapy will be of benefit or not. So, as I said, this is a really rudimentary set of curves that I drew out that suggested that at diagnosis or when we put these patients on study, they may have 3 Mets. But I have no way of predicting whether 6 months from now they have 20 Mets, 6 months from now they have 1 Met. And that information is vitally critical for us to better understand how to use local therapy in the most optimal fashion. And it's about is the disease that we're seeing the tip of the iceberg, or is it all the disease that we're going to see for years? And so, I'm not going to belabor the point, but there are a number of lessons that we can learn. And I'm just going to end with this slide. But the real key point is that until we understand with real world data and with kind of big data analyses, the disease trajectories of patients over time on certain therapies, then we really will not be able to personalize our approaches of using local therapy to manage patients with metastatic disease. But I would say for the time being, I think we're doing an incredibly good job of, at least with the limited data we have, identifying patients with oligoprogressive or oligometastatic disease. And we're actually seeing clinical trial signals of benefit in this patient population. So I think more information is needed, but the trials so far have been very encouraging. And I think this is a way for us to look in the future to add local therapy to systemic therapy, especially targetable agents, in order to optimize durability of treatment response. And with that, I'll end, and I thank you very much.
Really a wonderful discussion by Dr. Iyengar. Thank you so much. Next, it's my honor and privilege to be introducing our next speaker, Dr. Kristen Higgins. And she's an associate professor and vice chair of clinical research in the Department of Radiation Oncology at Emory School of Medicine. She serves as the medical director of radiation oncology at the Emory Clinic. She's board certified and she's on multiple professional societies, member of the NRG Board of Directors, and RTOG Foundation Communications Committee. And one of the things you'll see in today's program is it really takes a team to help best take care of patients. And we could be at an Astro plenary session and we'd get to hear from folks, some of Dr. Iyengar's and Dr. Higgins' caliber. And so with that, I'd like to invite her to join to moderate our discussion. Perfect.
Hello. It's good to be here. I hope everybody can see me and hear me all right.
Yep, we can see and hear you. And I gave you a very nice introduction, Dr. Iyengar will tell you. I left no stone unturned.
Wonderful. Yes, no, I thought Dr. Iyengar's talk was very good, and I think it succinctly touched on all of the points of using radiation in patients that have targetable mutations and take targeted therapy, and different times that we can come in with radiation and potentially keep somebody on their drug therapy longer. And it's really sort of an area where we see a lot of patients every day, and there's a lot of different and unique clinical scenarios that present themselves. But there are a lot of great questions, and I'm happy to pose some of these. I can ask one interesting question that I saw on the chat was regarding a patient that had a lung metastasis that was on targeted therapy and was wanting to get treatment with stereotactic radiation and wasn't able to hold their breath. And the question was, is it still feasible for the patient to get radiation? Do you have to use these breath hold techniques in order to deliver radiation safely? So Dr. Iyengar, what do you think about that? Do you want to give your opinion on what you do at Memorial Sloan Kettering in these situations?
Yeah, you absolutely don't need to be able to hold your breath to receive SBRT safely. Um, in fact, I would anticipate that a lot of our patients would not be able to for one reason or another. So we use something called abdominal compression. And basically what that is it's a little bit of pressure that's placed on the diaphragm, which kind of promotes you to breathe more from your accessory muscles, shorter, shallower breaths than from down below in your diaphragm. And that actually reduces the motion significantly of the disease that needs to be treated. So absolutely, most institutions should have that mechanism, and you don't need to hold your breath to get SBRT effectively and safely.
Another question that really comes up a lot with patients, and a question that was asked during your talk, is if radiation increases toxicities for patients that are on targeted therapy, and what do we know about the safety of combining the two?
I think, I mean, all of these studies that have been completed or, moving forward in the right direction, have asked that question very critically, because as we know, some of the TKIs can increase the risk of pneumonitis, and then you add that radiation to that. But the safety profiles so far have been pretty positive, in the sense that there hasn't been some overwhelming signal that would make us very concerned about using them together. I still hold the TKIs a few days before the SBRT till a few days after, an abundance of caution. Remember, the lesions that we're treating with SBRT are relatively small lesions. We should be able to protect the rest of your lungs. So far, I think the signals are positive about being able to use both together without significant toxicity.
Yeah, I would agree with that too. We at Emory, we presented our experience of Osimertanive with SBRT to mainly lung and bone lesions a couple years ago at World Lung, and we had pretty low toxicities. So I definitely agree with you on that point. I generally, when I'm seeing these patients, will call the medical oncologist and we'll have a discussion about whether or not the medical oncologist is comfortable with the hold on the TKI. And many times the medical oncologists I work with are not comfortable with stopping the TKI for radiation. So, more often than not, I am treating patients with the TKI on board, but I think the important thing from the patient point of view is to make sure that your doctors are communicating and that there's a plan for what you're going to do with the drug therapy while you're getting radiation, and everybody's on board and is in agreement with what's happening. Because sometimes, particularly if you are getting radiation at a different facility from where your medical oncologist is, the communication may not always be happening. And I think that it's just an important point as a patient that you can advocate for yourself and just make sure that your doctors are talking to each other and are on the same page when it comes to how you're taking your targeted therapy and if you're holding it during radiation. Do we have any comments on that from our medical oncologists on the panel?
I really agree with the points that have been made by both of you, Dr. Iyengar and Dr. Higgins. Unfortunately, there's no one universal approach that we take in terms of the overlap between the TKI and the radiation. In Boston, generally, our practice brief, where you don't have to worry as much about the flare of disease with the holding of the TKI. The discussion becomes much harder when the radiation has to be of a prolonged course, right? If someone's requiring 3 weeks or longer of a radiation course, then there really has to be a careful weighing of how much active disease burden is there at the present time, and then what area is being irradiated in terms of potential overlapping toxicities. Certainly with certain TKIs, for example, with Osimertanive, where we know that there's a pretty significant risk of pneumonitis. If there's anywhere in proximity to the lung that's being irradiated, we will definitely not overlap. Similarly with bowels, if we're worrying about diarrhea and bowel toxicities, then we will not overlap. And then with the brain, we're very careful as well. With a lot of the CNS penetrant TKIs, we worry about increased risk of radionecrosis. And so we generally try to overlap, overlap the Dr. Royce, do you have any thoughts?
Yeah, I would agree with that approach. I mean, I think, the last thing you also want to do is get in a scenario where then you do have a significant toxicity, and then you might have to hold therapy even longer because you ran into a toxicity, rather than knowing that by and large, if you restart this therapy, you should be able to get the response back. And, I don't think there's any data to suggest that holding the therapy will lead to increased risk of resistance or anything like that. So I think it's always better to err on the side of safety, especially when you really want to engender a long-term response with less toxicity.
Yeah, I completely agree. And I think I agree. My practice is sort of consistent with what Dr. Anger pointed out in terms of sort of peri-radiotherapy period, discontinuation or holding of TKI. I think that's, again, out of abundance of caution.
And I will also mention one of the things we can do from the radiation point of view is we can alter the schedule to try to make the amount of time where the TKI is held as short as possible. So that's another thing that you can sort of ask your radiation oncologist if that's possible, just to, instead of giving SBRT every other day, can you give it every day, for example? And that's a way that we can, I think, optimize our outcomes potentially. And so what about the question about our patients that have locally advanced non-small cell lung cancer and have driver mutations and receive chemotherapy and radiation? I know in our practice, we are not generally giving these patients immunotherapy, but I wanted to ask the panel, what are you guys doing in terms of targeted therapy for patients that you've identified to have a driver mutation?
Yeah, so I think, as I alluded to, this is an excellent question. I think it depends a little bit on the driver mutation, what therapies we have available. I think when you talk about classical EGFR alterations, ALK fusions, where you have really an excellent CNS penetrant oral targeted agent with an acceptable safety profile, I see very little harm and downsides to administering the targeted therapy after chemoradiation. We know that the risk of recurrence in these patients is even higher, typically, than even the stage 3 patients that have resected. They typically have a more advanced disease. And I think immunotherapy is very difficult to consider in that scenario, because if someone progresses on durvalumab immunotherapy and you then want to start the targeted agent, you start to wrestle with the toxicity. Do I need to hold out a little longer? What agent do I start? Do I dose reduce? And I think it's best to avoid those questions if you don't think that immunotherapy is likely to have a significant benefit. But again, not all mutations are created equally. I think KRAS, for example, we know there's benefit to immunotherapy. And then there's some mutation subtypes where they may not benefit from immunotherapy, but we just don't have a great agent that we can give long-term. You look at EGFR exon 20 with amivantamab or mobocertinib, or even some of the MET targeted agents, where you just worry about the ability for patients to take these agents for, 1, 2, 3 years or indefinite in that scenario.
Yeah, I completely agree with what Dr. Royce mentioned. I think it really depends on the mutation that we're talking about. And again, I think it's a very, I think it's something which needs a lot of discussion with the patient, because remember, I mean, even in the EGFR, classical EGFR mutation setting, we know that durvalumab may not be as good, but we don't know that osimertanive is the best, so to speak. I mean, it's the best we have, but we don't have really good phase 3 data. So again, with those caveats, I think there's a good amount of patient discussion that goes into that. But I agree with Dr. Royce, especially in the some of these newer mutations where we have decent data where there are second line approved agents. I don't think I would feel comfortable sort of starting them just post chemoradiation, given that, okay, immunotherapy is probably not going to be good enough.
We had another question in the chat that was asking about biomarker testing for early stage non-small cell lung cancer. And is it something that is routinely done now, given the recent data that has come out with the use of targeted therapy in early stage disease? So I guess just hearing from people and at their institutions, what happens for patients that have early stage non-small cell lung cancer in terms of biomarker testing?
Yeah, so I think at both. So I trained at Mayo, and we used to do, even for early stage, do biomarker testing. Now I'm transitioning to UAB. I think here also the practice is that, and as you mentioned, Dr. Higgins, as more and more data come out for the perioperative immunotherapy setting, which some of which Dr. Rose touched upon as well, I think it's important to test because some of these studies did exclude EGFR and ALK mutated disease. So may not be directly translatable to that. So definitely testing, pretty much all of our patients, early stage, advanced stage, except for possibly just stage 1 with the biomarker testing.
Yeah, and I'll say it's absolutely critical, but it's an even more challenging environment because you're oftentimes dealing with a smaller biopsy sample, perhaps a pulmonologist went in and did an FNA, a fine needle aspiration. So there's limited tissue. You want to know the histology, make sure it's not a small cell or some other different type of more aggressive lung cancer. And then, playing the waiting game and someone who you want to then go on to surgery, do you send that out for a full NGS and risk that there's not enough tissue? Do you do a more limited panel? I know at our institution, we're starting to actually kind of revert a little bit and do some more limited panel testing to some of the more, actionable kind of limited alterations. So we can at least get those answers quickly. So we can try to make, a decision, tumor-informed decision that still allows for a curative intent treatment approach.
I mean, I'm just going to add that, yeah, I mean, I think as patients, patient advocates, family members, it's and physicians and teams, it's on all of us to really push hard to make sure that the testing is done for early stage disease. It's relevant for disease that's resectable. I imagine very soon it's going to be relevant for patients who receive SBRT for early stage disease, for instance, because there may be some SBRT adjuvant immunotherapy trials that become mainstream. And if you have a targetable mutation, it may not be ideal for you to receive immunotherapy in the adjuvant setting. And so there are a lot of reasons why, for all indications, early stage disease, we should really push to get some form of testing up front.
And then what do you guys think is happening in the community setting? I know probably at your institutions, molecular testing is happening on all non-small cell lung cancer patients, but bridging the gap and make, we're having consistent processes for patients that are treated everywhere is, I think, a really important point. And I just wanted to ask about what your experience is with patients that are perhaps coming in from having been consulted on in a community setting and what you're seeing.
Yeah, I mean, I would say it's been variable, but I think it's getting more and more to the point that we are seeing more and more patients being tested in early stage setting, again, because some of the pivotal trials for perioperative immunotherapy did sort of exclude certain patient or certain subgroups of genomic altered patient, non-small cell lung cancer patients. I think the other important point we have to mention is, it's important to test because if we test and we identify, then we can offer clinical trials. I mean, Dr. Rose mentioned a few in the perioperative space with, tyrosine kinase inhibitors. So again, I think testing, there also becomes important to be able to offer these options for clinical trials.
And there was also a question in the chat asking about more rare mutations, RET, for example, if there were any opportunities for trials for early stage patients to receive targeted therapy that have more rare targetable mutations?
Yeah, so there are studies ongoing. For example, with RET, the libretto studies. That's kind of the generic name of these RET targeted therapies. With I believe that's with selpercatinib, given either before surgery or after surgery. But again, I think this is a scenario where if we don't have data, but we know we have highly effective targeted agents that have good CNS penetration and are relatively well tolerated, I think that's where you can really have a discussion with your provider of, is an off-label use of this appropriate in this scenario? I mean, I think the RET targeted agents do check a lot of those boxes, again, of an agent that is effective with good penetration into the brain and that's reasonably well tolerated, where I think an approach similar to osimertanib after surgery, similar to Adora, can be mirrored for these patients.
I think the two key messages of several others that all of the attendees are hearing today from all of you speakers is that, one, you have to make sure all the biomarker testing has been performed, right? Because that is the starting point for all of our discussions today. And second, that in the postoperative setting or perioperative setting, we not to just default to immunotherapy. Even if, for example, PD-L1 biomarker level is high for these certain targetable genomic subsets of lung cancer, just defaulting to pembrolizumab or atezolizumab after concurrent approval for these agents. And so those two things I would really encourage all of the attendees to remember is making sure all the genotyping and biomarker testing has been done, and then making sure we are not just defaulting to immunotherapy depending on the specific type of lung cancer that you have.
That's a great message. There was one other question in the chat that was referring to squamous cell carcinomas, asking if biomarker testing should be done on patients that have squamous cell lung cancer.
Yes, so I think traditionally, obviously, we've thought of these genetic alterations occur more commonly in non-squamous adenocarcinoma, subset of non-small cell lung cancer, which is obviously true. But I think increasingly, even in high smoking population, we are able to identify certain alterations to which we may have targeted therapies. I think if you look at the NCCN guidelines, I don't think they actually differentiate between non-squamous and squamous in terms of testing paradigms. So even though it's probably going to be less frequent for us to find, and I think in a particular situation where we have a high smoking population where we're not able to get tissue or ctDNA to identify for these biomarkers, in those sort of special situations, it's okay to go ahead with treatment if we are able to identify other biomarkers with PD-L1. But I think in most cases, I would say, regardless of squamous or non-squamous, I think biomarker testing will be very helpful and indicated.
And I'll add too that I think smoking status does matter here as well. Now we know that patients who have never smoked who get squamous lung cancer, that's a very rare population. But we reported on some data looking at the CARIS Alliance. We reported on some data at ESMO that showed in never smokers, there is actually an increased enrichment for some of these alterations like EGFR and MET in squamous lung cancer as well. So I would agree with Dr. Desai. I would do genomic profiling on all patients regardless of histology, but certain factors like smoking status might kind of affect the pretest probability of seeing one of these driver alterations.
And then from the patient point of view, when you develop resistance on a targeted therapy, what should they be asking their doctors? What are the important things that the patient should be aware of when their cancer starts to progress? Can you offer any pieces of advice when a patient reaches this point in their journey?
I can start us off. I think some of the key questions to ask are, first of all, where is the cancer progression happening? So we really care about the location and also the pattern of progression. Dr. Iyengar is touching upon whether the number of sites that are changing versus diffusely multiple sites throughout the body. Greatly impacts how we think about a potential role for local therapy like radiation or ablation or sometimes even surgery versus switching the targeted therapy treatment option. So that's the first important question, is where is the progression occurring and what's the pattern of progression? And secondly, if we're at a point where we are having to switch the actual medication, then what are the options and how will we decide which one is most suitable for my specific cancer? Really trying to personalize the subsequent therapy as much as possible. And there, it can be helpful to consider repeat biopsy, although there can be variabilities in access and insurance coverage there as well. Then doctor decide what's your practice and what do you discuss kind of in terms of broad strokes when someone is progressing on targeted therapy?
Sure. Yeah. I think first and foremost, too, in addition to kind of whether this is a limited progression or a more advanced progression, is also then discussing biopsy, because we know that sometimes the way that the cancer can kind of outsmart the treatment might be in a way that we have another therapy that's available in an off-label scenario. I think we all have seen this with MET alterations or other fusions where we might be able to add an approved targeted treatment to our arsenal to extend the benefit. Also, we know that the cancer can sometimes look different. So if it's an adenocarcinoma, it might transform into a more aggressive small cell lung cancer. And so I think biopsy is super important there and is important in informing the treatment selection and whether there's something approved. Do we add in chemo or do we look for a clinical trial option?
Yeah, I completely agree with everything that's been said, including the fact I think it's most important to identify whether this is sort of what we call oligoprogression or progression at a limited number of metastatic sites, where we can collaborate with our radiation oncologists or surgical colleagues to see whether there is any local therapy that we can offer while continuing the systemic therapy that has hopefully worked, for a period of months to years. But I think when there is systemic progression, as Dr. Royce mentioned, I would agree that, tissue biopsy is important specifically to look at whether the cancer has sort of changed its colors or transformed into a different histology where the treatment paradigm may be different, more focused on chemotherapy if it's small cell lung cancer, for example. And then I think when tissue biopsy is not feasible, I think I'm increasingly incorporating liquid biopsy in this particular instances where I'm trying to plan systemic therapy in second line or subsequent lines, hopefully based on resistance, the mechanism of resistance. Particularly for EGFR and ALK, and probably other, genetic alterations as well. There are newer generation TKIs that are coming up, which may be more effective against, the common resistance mechanisms. For example, with Osimertanive, the C797S, there are other newer next generation, fourth generation TKIs that are currently in clinical trials, which may be more effective in those cases. So again, very important if we can, again, from a biomarker testing standpoint, even in the relapsed, setting, again, for identification of the actual resistance mechanism, as well as enrollment in clinical trials to really target. I think of this as like precision oncology 2.0, like sort of doing it all over again, to make sure that we are really targeting the cancer where it's being resistant to the current treatments.
One other thing I will add is we also looked at the pace of the cancer changing. So we ask, is the progression causing symptoms, or is it very kind of slow, what we call indolent? Some of the lung nodules may be growing by 1 or 2 millimeters each scan, and it's really not causing any symptoms. In those scenarios, it's changing therapy right away. If you're having a great quality of life, no side effects from the medication, and it's by and large doing a really good job, the medication is by and large doing a good job controlling the cancer, then sometimes the doctor may recommend continuing to watch for now and seeing what the next scan shows before we rush to doing a biopsy or changing the medication. So you may hear about that approach as well from the doctors.
Those are all very good points. I have 2 questions now for Dr. Iyengar. One of them is asking about the role of surgery for local therapy for patients that have oligoprogression on TKI. And then the second is regarding the use of radiofrequency ablations specifically for adrenal nodules and if that is an effective local therapy. So if you could comment on both of those.
Sure. I think surgery is a very reasonable approach in treating oligoprogressive lesions that are amenable to surgery. Most places, we really should take a multidisciplinary approach to talk about what is the right modalities. We shouldn't jump straight into radiation. We shouldn't jump straight into surgery. We should not even consider local therapy unless it's a multidisciplinary decision. I think that's really the best approach. But surgery is definitely on the table. A number of these studies incorporated surgery. It just happens to be that it was used about 25% of the time in some of the studies, and radiation about 70 to 80% of the time. But it's a very reasonable approach. Isolated lesion in the lungs, you can have a segmentectomy, or you don't need a necessarily lobectomy. I think it could be very good. Now, with respect to radiofrequency ablation, I saw the question, and part of the rationale for the question was that the patient wanted to stay on his or her TKI and was worried and was thinking that ablation would allow them to do so with less toxicity. As Dr. Higgins pointed out, we can get patients in for radiation in and out extremely quickly these days. We can even do one fraction SBRT regimens that would provide some durable outcome in adrenals. We could do 3 fraction regimens. We could do things very quickly. And so for those institutions that choose to put the patients off the TKI for a few days, this really ends up being a few days. And as Dr. Royce mentioned, there's really limited data to suggest that the disease is going to become resistant within that short time frame that they're off the TKI. And then the final thing I'm going to say is that there's just not a lot of randomized data, even early, small, randomized phase 2 type of data of any kind, let alone very rigorous prospective collected data that suggests that ablation is a durable treatment for metastatic disease. When do I use ablation? I use ablation if I've treated a patient with SBRT. There happens to be an in-field failure, unfortunately, which is rare. And then I can't radiate again. Then I refer the patients for ablation.
That's exactly how I use radiofrequency ablation as well. So we tend to go the SBRT route and then use it for salvage if we need to. I have a very good question next. It's kind of the $1 million question that I want to pose to the panel. Somebody asks, what could patients do to help close the biomarker testing gap?
Yeah, it is a very important question. And I think, as I mentioned, a lot of this comes down to being aware, like awareness of, the biomarker testing, being able to, I think Dr. Rose's slides had ask and advocate. And I think that's very important. As a patient, you want to, at every stage of where your cancer treatment is being discussed or sort of changed, you want to ask your oncologist, that do I need to repeat biomarker testing? What are we basing the decision on, to really trying to understand, what their biomarker testing is from a cancer standpoint. What does their cancer sort of genetically look like? I know obviously we rely a lot on electronic health records. I advise my patients, and I usually print out their biomarker testing results and have them keep a copy as a document, because when they go from one healthcare system to another, this is sort of the thing that's sort of lost in translation, buried in fax machines and whatnot. And so I think it's very important if, for them to be aware, sort of really have that document when they are trying to seek a second opinion or something, to actually, have that to be able to show and get a decent opinion on what the next step would be, from each oncologist. And I think from a caregiver standpoint, again, I think it's important to understand what your loved one has in terms of biomarker testing, what is needed, and again, being there in the clinic, asking questions, noting down the questions you want to ask for your treating physician, as to how are we going to sort of decide the next line of treatment, or this particular line of treatment, why are we doing this? Can we do something more targeted? I think those are the questions really to ask for.
Dr. Lin or Dr. Roos, do you have anything to add to that? I think that was a great answer, Dr. Desai, to a hard question.
Yeah, I agree wholeheartedly. And I think I already see patients making a difference, actually. I have seen second opinions where patients come and tell me, I had heard from a friend of mine that this absolutely needs to be tested for. And so I asked about it and it was done. And this is what we found. I think sharing your stories can be really powerful in terms of how the biomarker test and what it's led to in terms of treatment options. In the patient advocacy groups, that can be really helpful as well. So I think many of you are already doing to kind of spread the awareness, and continue to do so will be very important.
Absolutely. We have another kind of general question that just came through the chat. What are we learning about prevention and causes of lung cancer? Does the US have a higher incidence, I guess, to other regions in the world? One of the oh, sorry, go ahead.
No, I was just going to mention, I mean, we are obviously, there's a lot of research being conducted in terms of like the causes of lung cancer. I mean, just a few months ago, there were a series of papers from the UK about air pollution and how air pollutants can lead to lung cancer, even in patients who are never smokers. So I think there's obviously ongoing research. We're learning a lot in terms of what kind of particulate matter may be responsible for lung cancer. In terms of prevention, I mean, there are increasingly, I mean, at least in the literature, I'm seeing increasingly number of different models we are using to identify. There's AI-based, CT lung cancer screening models to see whether we can, really predict which lung nodules may develop into cancer. So there's a lot of ongoing research, but I think just in general, etiology, prevention, sort of this epidemiological research is very difficult just because it's not, as simple in the terms of understanding that you have a cancer, you treat it, it shrinks, then it's working, So I think that's why some of the roadblocks to actually our understanding, but it still has gone a long way since we started.
I think another interesting kind of side aspect to that question is, can we actually screen more patients for lung cancer? Are our screening guidelines really encompassing the maximum number of patients that should be screened for lung cancer? And for example, Dr. Elaine Shum at NYU is leading a very interesting study at looking at lung cancer screening for young Asian female never smokers, because we do know that this is a population that might be at greater risk for some of these driver mutation lung cancers. Now, that's not everybody, obviously, and we, at the end of the day, can't screen everybody for lung cancer, but I think asking what populations warrant additional screening so we can detect these cancers earlier and cure more of them is also an important aspect to that question.
Progress is being made slowly but surely, and I think what we can do is, what patients can do is for all the people that are former smokers or active smokers, just really advocate that they ask their PCPs to order a lung cancer screening study. It's still so underutilized in the United States, even though there's great data to support lung cancer screening, and it's something that is low-hanging fruit that I think everybody that is a lung cancer survivor can really help us with by just spreading the word to your community, your circle, your network, your family, your friends. And hopefully we can see that improve over time. I do have a question for Dr. Iyengar related to the role of specifically CyberKnife in somebody that has a stage 4 lung cancer with an exon 20 EGFR mutation. So could you speak, I guess, generally about the type of SBRT, the platform that's being used, and if that is any different, if it's CyberKnife versus Gamma Knife or what have you?
They're absolutely right, Dr. Higgins. There's multiple platforms that can deliver SBRT. For instance, in the brain, it's called SRS, but it's the same concept. And there's a Gamma Knife type of machine, and there's traditional LINAC-based approaches to treat brain mets. Below the neck or from the neck down, you can use multiple different platforms as well. CyberKnife is a platform. It's been effectively utilized by a number of investigators and physicians. It has a little bit more unique aspect that you place what we call a fiducial in the lesion, which is detectable by the machine, which can then use that to monitor movement and then deliver radiation specifically to that fiducial marked area of disease. So it's highly conformal, meaning it's highly localized. It's specific to the tumor. You could probably use reduced margins a little bit to try to deliver the radiation. But in general, I would say that all of the platforms work quite well and effectively well to deliver SBRT type of radiation doses and fractionations to the disease. We would not necessarily, whether it's specific type of mutation, each specific type of EGFR mutation at this stage doesn't drive use of a specific platform or a specific machine, but they're all pretty solid, I think.
Thank you for that. And we're coming to the end of our panel discussion, but one question just came in that I want to pose to everyone, and I think it's a great question. There are a lot of patients now that have been on TKIs for a long time, long haulers. Do we know what is enabling these patient successes? Why are they not developing resistance? What's known about these outliers that are doing so well on TKIs for many, many years? Dr. Lin?
So this is an area of a lot of research that's happening right now. I agree that that is a very important question. We don't answer quite yet. We know that in certain subsets of lung cancer, such as, for example, EGFR, ALK lung cancer, there's data to suggest that certain co-mutations can correlate with shorter duration on a TKI targeted therapy, or P53 mutation is a well-known one, where when there's a co-mutation in P53 with these drivers like EGFR mutation or ALK fusion, retrospective studies are showing that patients who do have co-mutations can have sometimes shorter time to cancer progression. But I think we're really touching at the tip of the iceberg right now, and there's still a lot more work to be done looking at for fusions, different fusion variants and impact on outcomes, total mutational neoantigen landscape, and whether that correlates with outcomes. And all of that research is still ongoing.
And actually, one other question just came in, and maybe we can end with this because I think it's a very practical one. When you are seeing a patient and you get PD-L1 results back and it's high, but you don't have the results of NGS, what is your approach for initiating therapy for these patients that have metastatic disease?
Yeah, so I think that's an important question, one that we still see as second opinions. I think when we're on talks with other physicians in the community, I think this point is still raised. And I think it's important, you still have to wait for the molecular testing. You can't go off of PD-L1 alone. We know that in these driver patients, patients with drivers, especially EGFR, that even if there's a high PD-L1, that does not indicate a potential ability to respond to immunotherapy. We've seen that proven in clinical trials. So, I think you can still look at that and say, all right, maybe that will help inform the decision when the rest of the results come back, but absolutely you should not act off of PD-L1 alone.
Yeah, I completely agree with that.
Great.
I am on the same page as well. I think the question becomes whether you have to at least get a cycle of chemotherapy in while the genotyping is pending versus being able to sit still and anxiously wait. Where that decision has to be made. We really look at the symptom, the burden of cancer on the imaging, and take all of that into consideration in guiding that treatment decision making.
Well, this was a really interesting panel, and I have to say our patients posed very interesting questions, and you all are extremely educated on this disease, and I think that's amazing, and please keep it up and keep pushing us to move faster and make discoveries so that we can, eventually make lung cancer a curable disease for everyone. So thank you guys very much.
Thank you so much, Dr. Higgins, for a wonderful session. It was a really rich Q&A. Thank you. So everyone in the audience, we are now going to be breaking for lunch. Please return at 12:30 p.m. Eastern Time, 9:30 a.m. Pacific Time. This will be for breakout session. As a guidance, the main stage will be and KRAS. And then the secondary stage will have the ALK, ROS1, RET, and other rare fusions. So please come back in just about 30 minutes and we'll continue. Thank you very much.
Hey, Maria, are we backstage?
Yes. Could I get you to mute your microphone and turn your camera off for just a little bit? Thank you very much. I'll message you in just 1 second. Okay, this is Maria Christian with Grace. I wanted to thank you for joining us today. I'm going to welcome everybody back to our first breakout session. Just a reminder, if you are looking for the other breakouts that are ALK-ROS1, RET, and rare fusions, those are in the second stage breakout room. You can see that to your left of your screen. This one we will be discussing KRAS and EGFR. So with that, I'm going to go ahead and hand things over to Dr. Isabel Prishigl.
Hi, everyone. Thank you so much. I'm just going to go ahead and share my slides. Give me 1 sec. I'm just troubleshooting here. How are we doing? Can you see this if I make it large?
Yes,
How about
you
there?
should be able to. Oh, that's perfect.
Okay, wonderful. So hi, take two. I'm Isabel Prishigl. I'm a thoracic medical oncologist at Memorial Sloan Kettering. I am so thrilled to be here, and thank you so much for inviting me. I look forward to hearing and learning from all the upcoming presentations, and also entertaining your questions and doing my best to answer them. So I have been given the task to give a talk on EGFR altered non-small cell lung cancer in 20 minutes. So this is going to be a tour de force. I'm going to do my best. But please understand that this is just very high level, and I'm just scraping, the surface here. There's much more to be learned and much more to be said about this topic. Here are my disclosures. So today I'm going to talk about the evolution of lung cancer treatment just briefly, talk about non-small cell lung cancer in the advanced stage setting, resistance alterations and mechanisms, early stage disease in the EGFR space, ASCO updates, because I'm sure you're all curious about those, although I'm sure you've heard much about them already. And then I'm going to summarize everything with some take-home points. So as you can see, lung cancer first started off as just lung cancer. Then we understand that there's non-small cell and small cell. Then we understand that there's more histologic breakdown like squamous and non-small cell and large cell neuroendocrine. And then we move on to molecular pathology, and we start to understand that there's more than just histologic breakdown. There's driver alterations and fusions that could be driving this lung cancer growth. So that's where my topic is going to be focused today, specifically on those that harbor EGFR alterations. So in 1999, we really didn't know all that much about lung cancer. 79% of alterations were unknown. Now fast forward to 2023, and this is what we are dealing with nowadays, plus more. So what do we do with this data tsunami? I'm going to try to make some sense of it in the EGFR space, but I have to be very honest with you. It is a huge task, and I rely on my colleagues. I rely on learning from my patients and reading as much as I can every day, to be honest, because I certainly do not know it all. So let's talk about EGFR in the advanced stage or stage 4 setting. So as we all know, these are the drugs that are approved for EGFR stage 4 disease. Osimertanive is the most common drug that I'm sure you've all heard about. This is the given frontline for patients with non-small cell lung cancer that harbor an EGFR alteration. These patients are typically about 10% of the patients with non-small cell lung cancer in the United States. It's commonly seen in patients with no smoking or minimal smoking history, but I have seen patients with a smoking history that harbor EGFR alterations, so this is not an end-all be-all. It is more commonly seen in the female population and typically those from East Asia, but that is also not an end-all be-all. Some of the more classical mutations are exon 19 deletions, L858R mutations, or exon 21. Those make up the majority. However, there are atypical EGFR mutations like G719X and L861Q, et cetera, as you can see here, as well as EGFR exon 20 insertions that you're going to be hearing about as well. So some of the key toxicities of these tyrosine kinase inhibitor drugs that we use to treat patients that harbor this alteration is really rash and diarrhea, but that is not the only side effects. Sometimes we see pneumonitis, we see paronychia or nail changes, and we can see thrombocytopenia or other cytopenias, meaning your certain lines of our blood count can go down. Most commonly, I see platelets. So now we need to talk about, well, what can we do? Do we just give patients osimertinib or tyrosine kinase inhibitors alone? Or is there a role to combine these tyrosine kinase inhibitors with other chemotherapy agents or VEGF agents? And here's just a high-level overview. There are some studies that explored combining erlotinib with bevacizumab, which is a VEGF inhibitor. It was a phase 2/3 study, and there was definitely a progression survival advantage, but no real overall survival advantage when adding bevacizumab to erlotinib. When adding ramucirumab to erlotinib, there was a phase 3 study done in this space, and there was also a progression-free survival advantage, and this is approved in the United States. Osimertinib was looked at combined with bevacizumab in a single-arm phase 1 study just to evaluate for safety. And in EA1582, we are looking at osimertinib plus or minus bevacizumab. And the reason that I highlight this study is because it allows patients that have brain metastases. And I have to be honest with you, this is commonly an exclusion criteria, meaning a criteria where patients that have brain mets are not allowed on study. So any study that allows patients with brain mets always catches my eye because, as we know, unfortunately, lung cancer has a very strong propensity to metastasize to the brain. So if we could have any patients that have brain metastases be included in these clinical trials, I think we need to keep our eyes and ears open for those trials, because these are the true patients. This is a true representation of who we're seeing in clinic, and they should absolutely not be excluded. So that's combining tyrosine kinase inhibitors with VEGF inhibitors. When we're looking at combining tyrosine kinase inhibitors with chemotherapy, there's a FLORA study that's looking at stage 4 disease that's randomizing osimertinib plus platinum doublet chemotherapy, followed by platinum and osimertinib maintenance versus osimertinib alone. So stay tuned for that space. I had told you I was going to briefly talk about resistance mechanisms. So resistance mechanisms basically means when osimertinib or erlotinib or any of the tyrosine kinase inhibitors that you're on stop working. Why do they stop working? They stop working because your lung cancer got smarter than the drug. So how does the lung cancer get smarter than the drug? Well, there's lots of different ways that it can outsmart the drug. And we are just starting to learn about this. But here are the most common ways that I've listed, but there are many other mechanisms that I am unaware of and that we have not learned about yet. So this talk is evolving. But we have on-target resistance mechanisms and off-target. On-target would be developing a secondary EGFR mutation. And an off-target would be developing a different kind of alteration, like MET amplification, or a RET fusion, or an ALK fusion, or a BRAF alteration, or HER2 amplification, or a HER2 mutation, right? So identifying what is causing the drug to not work anymore is essential. So anytime you are on a drug that's not working, I really want you to advocate for yourself, to ask your oncologist to biopsy an area that's growing and to send a liquid biopsy, to send next generation sequencing on that tissue biopsy and in your blood to identify if you have any of these resistance alterations, because there are clinical trials that you could go on or be, at least privy to, that will help target these resistance alterations and give you a little bit more of a targeted therapy approach for your next line of therapy rather than chemo. However, if there is no resistance alteration identified, as you can see here in the orange, you may be more appropriate for standard of care chemotherapy or a different kind of clinical trial. And then we have lineage plasticity, which is when your non-small cell lung cancer has completely transformed to small cell or to squamous, in which case we need to start looking at small cell chemotherapy regimens or squamous cell chemotherapy regimens, because this unfortunately is a poor prognostic factor. and identifying it as quickly as you possibly can so you can get on the appropriate treatment is essential. So what do you do when osimertinib stops working? Obviously, you look for those resistance alterations, but still to date, standard of care post-osimertinib is chemotherapy. However, there is a new drug called patritumab deruxtecan, and patritumab deruxtecan is a HER3-directed antibody drug conjugate. And an antibody drug conjugate is basically where you have an antibody and on one side you have a linker, which is like the warhead. So I think of this almost like a Trojan horse, right? You have the antibody, which is the Trojan horse that's coming in, and then you have the warhead inside of the Trojan horse. So the Trojan horse comes in and looks pretty innocent, and then once it binds to the tumor cell, the warhead is released and goes inside of the tumor cell and kills it. So this is a HER3-directed Trojan horse, you could say. And the reason HER3 is important is because HER3 is actually expressed on the majority of non-small cell lung cancer cells that harbor an EGFR mutation, so the perfect target. So when looking at patritumab deruxtecan in this space, there was about a 39% response rate, and now it's being investigated as monotherapy and in combination with osimertinib. In addition to patritumab deruxtecan, we have two other drugs, amivantamab and lazertinib. In the EGFR exon 20 talk, you're going to hear a lot about amivantamab, but there is some role for it in this setting as well. Amivantamab is a MET EGFR bispecific antibody, and lazertinib is a third-generation tyrosine kinase inhibitor. Lazertinib is a pill, and amivantamab is an IV infusion. And combination therapy was assessed after osimertinib and before chemotherapy, and it actually demonstrated a 36% overall response rate. The toxicity was considered similar to tyrosine kinase inhibitors, plus the infusion reaction that we typically see with amivantamab on the first day of the infusion, as well as GI toxicity. So there are ongoing studies in this space looking at it in the frontline setting and later line settings. So let's get to the meat of the talk, which is the ASCO 2023 EGFR highlight reel. And these were just, abstracts and presentations that caught my eye, but there may be other things that are more interesting to you or more interesting to others. So this was just my thoughts. So here are the topics I'm going to talk about. Two studies in the neoadjuvant adjuvant space and 3 studies in the metastatic setting. So neoadjuvant adjuvant space is early stage lung cancer. The Adora I'm going to talk about in the adjuvant setting, and the NEO study in the neoadjuvant setting. And then the metastatic setting, Keynote 789, Everest, and then Blue 945 Symphony. So let's talk about Adora. I'm sure you've heard a lot about this study. So this is a study in the adjuvant setting, meaning these patients had resected early stage lung cancer, and then they received, chemotherapy, and they were randomized to receive osimertinib or placebo for about 3 years ongoing. So we had been hanging our hat and using osimertinib in this setting based on the disease-free survival benefit that had been presented at ASCO previously. And we were all anxiously awaiting the overall survival, right? Because you want to know if you are going to go on this drug, you want to be sure that it's going to make you live longer, right? So we finally have this data, and I'm really excited to review it with you, although I'm sure you've probably heard a lot about it already. Anyways, this was beautifully presented at ASCO 2023 by Dr. Herbst. So here's a brief schema of the study design, but basically, as I had said, it's patients that have had completely resected stage B, 1B to stage 3A non-small cell lung cancer that harbored an EGFR alteration exon 19 or L858R. And these patients were completely resected, and they received chemotherapy, and some of them did not receive chemotherapy afterwards. But as you can see here, it says 10 weeks without adjuvant chemotherapy or 26 weeks with adjuvant chemotherapy. So there was definitely a stratification there. But after that time period, they were either randomized to receive osimertinib or placebo, ongoing for 3 years plus. And here are the baseline study characteristics. And something that I really want to make sure that I pay attention to is that the arms are equal, so that those that got osimertinib were equal to the same amount of patients that got placebo. that the age was fairly comparable in both arms, that the performance status, the histology, the mutations, the staging, everything looks pretty comparable in both arms. And here we have a Kaplan-Meier curve looking at the probability of overall survival. So osimertinib is in the red arm, as you can see on the top, and the placebo is in the blue. And you can see that there is a nice separation of the curves. So even just from looking at this, you can kind of get a glimmer that there probably is a survival advantage to take osimertinib after you've had resected disease if you have an EGFR alteration. However, it's always nice to see this statistical analysis and the data. So that's why I put the little blue star there, and you can see that there's an 88% 5-year overall survival advantage for those that received osimertinib, and a 78% 5-year overall survival advantage to those that received placebo. And the p-value is significant, and the hazard ratio is 0.49, which is a very nice hazard ratio that we like to see here. So there is a clear overall survival benefit to receive osimertinib after you had a resection if you are stage 1B to stage 3A. So what's the meat of this study? Basically, as I had said, there's an overall survival advantage to receive osimertinib. I told you the 5-year overall survival rate was 88% with OC versus 78% with placebo. However, I still have some questions. Do we adore Adora? So I found this term from JAMA. I know it's coined. I stole it from Dr. West, so thank you for that. I did give him slide credit down here. So my real question is, what's driving this overall survival benefit? Is it that we're just delaying the inevitable that this cancer could come back, or are we truly curing? And I don't think we know the answer to that. Obviously, I'm happy about this data, but that question is just always in the back of my mind. And there's always the risk of toxicity, right? So there's this beautiful slide that Jill Feldman, who's one of our amazing EGFR advocates and patients, puts up, where she looks absolutely wonderful on this slide. And you would look at her walking in the park and not think anything, but she has, muscle wasting, she's fatigued, she has mucositis, she has a rash, she has, weight loss, she has just all these other things you would never know about. So toxicity is huge, and taking this drug for 3 years or maybe even longer with, with a survival advantage, but still, is it worth it to you? And that's why I really think you need to talk with your oncologist before you sign up for this. So let's briefly talk about NEOS, which is a phase 2 trial of neoadjuvant osimertinib for surgically resected EGFR mutated non-small cell lung cancer. So we're talking about neoadjuvant, which means giving osimertinib even before you go to surgery. Adora, I told you that we were giving osimertinib after surgery. So this is looking at osimertinib before surgery. So I just tried to cut to the meat here. And basically, this was a multi-institutional phase 2 study looking at neoadjuvant osimertinib for patients with surgically resectable stage 1 to stage 3A disease. Unfortunately, this study did not meet the primary endpoint of major pathologic response in 50% of the patients. You're probably wondering, well, what is major pathologic response? You probably hear this term, and some of you may know, but I always need a refresher. And it means that when you take that tumor out after you get neoadjuvant chemo or neoadjuvant some kind of therapy, and you send the patient to surgery and you take that tumor out and you look under the microscope, you need to make sure that you see 10% of viable tumor or less. So if you take out that tumor and the whole thing is viable, then you have to think maybe the treatment that I got before I went to surgery didn't do a great job at killing that tumor. So a major pathologic response means that 90% of that tumor is dead. So they were really hoping to see that in the majority of patients, and unfortunately, they did not. That doesn't mean that there is no role for osimertinib, but it unfortunately was not what they wanted to see. So I'm going to move on to the studies at ASCO in the metastatic setting now, okay? And the first one is Keynote 789. So Keynote 789 was a phase 3 randomized study, and it was basically looking at patients that harbor an EGFR alteration, exon 19 or L858R with a good performance status, and they were randomized to get chemotherapy with immunotherapy or chemotherapy alone. And the main question here is, do patients with an EGFR mutation benefit from immunotherapy in this setting? So here are my thoughts. There was a trend in progression-free survival and overall survival. However, it was not statistically significant. Those with a PD-L1 positive disease may have had a slight benefit with a hazard ratio of 0.77 versus those with PD-L1 negative 0.91, but I'm not buying that. Stay tuned for chemoimmunotherapy and anti-angiogenesis agents like bevacizumab and ramucirumab in this space, as there may be some activity, but it's questionable. So long story short, this was a negative study in my mind. It did not show that immunotherapy helps patients in this setting that have EGFR mutations. So even though this was a negative study, it's important to talk about negative studies because that's how we learn as well. So I don't think this was practice changing for me. Now let's move on to Everest. So Everest was another study that was presented at ASCO. It's a randomized phase 3 study of first-line zorifertinib versus gefitinib or alatinib in EGFR mutated non-small cell lung cancer patients with CNS metastasis or brain metastases. Remember, I told you that's a buzzword I always look for. So let's talk about this study. These patients had stage 4 disease, they harbored an EGFR mutation that was driving their disease, and they had brain metastases that were asymptomatic. So what did we find? We found that there was an improved progression-free survival of zorifertinib compared to gefitinib or alatinib. The PFS hazard ratio was 0.7, and the intracranial progression-free survival hazard ratio was 0.467, so even better. And interestingly, those that harbored an L858R alteration had a slightly greater benefit. That's EGFR exon 21. And typically, patients that have L858R alterations compared to exon 19 deletions have a slightly more aggressive disease. So anytime I see a benefit for L858R patients, I feel like that's a little bit of a win for me, and I get a little excited. But cut to the chase, my thoughts. I don't love that this study compared zorifertinib to gefitinib and erlotinib. I wish they compared it to osimertanive. I think it would have been a little bit more up to date. I know that's not possible all the time, but I don't love the comparator arm. I think it could have been stronger. There was a lot of toxicity, unfortunately, that required dose reductions. So my question is, if we're reducing the dose of zorifertinib, is the drug penetrating our CNS? Is it getting past the blood-brain barrier and treating those brain metastases? Unclear to me. There may be an option for zorifertinib where osimertanive is not available, because I know it is still not readily available across the world, but stay tuned. Now we have Symphony, which is also known as Blue 945. Here is a brief schema. Basically, these were patients with stage 4 disease harboring an EGFR mutation, and they were randomized to get Blue 945 as monotherapy or Blue 945 plus osimertanive. So cut to the chase. Blue 945, what is this drug? This is a 4th generation tyrosine kinase inhibitor. So we have 2nd generations erlotinib, gefitinib, we have 3rd generations osimertanive, and now we have this 4th generation Blue 945. And the thought is that the more developed we get, the more refined the tyrosine kinase inhibitors are. So we noticed that there was a lot of toxicity, transaminitis, fatigue, nausea, vomiting, hyponatremia, unfortunately, with this study. And while there was tumor shrinkage, it's still not ready for prime time. So the combo is safe, Blue 945 plus osimertanive, and there's further development moving this into the frontline setting. So take-home messages from today. Adjuvant osimertanive, based on the Adora data, does have overall survival advantage, right? For stage 1B to stage 3A. There is no clear role for immunotherapy in the EGFR space yet. Zorifertinib is not clearly superior to osimertanive as it was compared to gefitinib and erlotinib. We need a better comparison arm, as I had said. Symphony Blue 945, the 4th generation tyrosine kinase inhibitor. Curious about its efficacy in the frontline setting and its efficacy when combined with osimertanive. We still don't know what to do post-osimertanive. So if your cancer grows on OC, I still don't have the perfect answer for you, but look for resistance alterations, and there is more work that needs to be done in this space. So long story short, lung cancer is complex. One size does not fit all, and it gets more complex as the day goes on. So advocate for yourself, ask questions, attend these conferences, and just know that we're here for you. I put my name on there. I put my email on the front. I welcome emails. I welcome messages. I hope to hear from you. I'm your advocate. Thank you so much, Cancer Grace, for having me and inviting me back. Thank you to my MSK team, and of course to our patients and their caregivers.
Thank you so much, Dr. Preciable. That was wonderful. We are going to bring in Dr. Sabari now. And let me see, let me make sure you are able to present. There we go. All right, I will hand it over into Dr. Sabari. Thank you.
Thank you so much. I appreciate it. Let me just pull up the slides here. All right, so everyone see it in slide mode? All right, great. So my name is Josh Sabari. I'm a thoracic medical oncologist at NYU Langone Perlmutter Cancer Center. And what a great discussion by Dr. Preciable, and looking forward to the questions and the discussion in the next session as well. We're going to focus on KRAS G12C. So talking about translating cancer discovery, how to target KRAS G12C in this setting. These are my disclosures. So non-small cell lung cancer has become a very complex space, as you've just heard.
Excuse me, sorry. Dr. Sabari, your slides aren't showing. If you'll just hit the presentation mode.
Hold on one sec. I'm sharing. Let me go back.
Technology.
Share screen or share video?
Share screen.
Entire screen, okay. Window?
Yes, does it show
Not
on your
showing?
screen?
Yeah, it shows on mine. It says sharing.
Okay, can you, in that screen, can you go to the bottom and hit the full presentation button?
It's in full presentation.
Okay.
All right, let's see. One more thing. No, that didn't do it?
Nope, it's still showing like when you're building it.
What about that?
Let's hit share and see. This is not showing you sharing on mine right now.
All right, let's troubleshoot one more thing.
Okay. And if it shows in the small mode, that's fine too.
Hold on. Did that work?
No, I saw lots of pictures of you. Let's let's go back to the way you were doing it originally and see if that will do it.
All right, hold on. Sorry about that, everyone.
Oh, it's just how technology
Share
works.
screen. Entire screen? No, window, right?
Window.
And I click on the PowerPoint. I hit share. Do you see that?
Okay, let me see. Yes.
Okay, now I make it large. Do you see that?
Well, yep, that's fine. We'll go with how it is right there.
Is that not in full mode?
It's good. It'll show. Everybody can see it.
All right. So sorry about that. These are my disclosures. And we were talking about non-small cell lung cancer being a complex space, and the treatment paradigm has changed rapidly. We'll focus on stage 4 non-small cell lung cancer here, where we're focusing on targeted therapies, chemotherapy, and immunotherapy as the treatment paradigm of choice. So going back, 5 to 10 years ago, first-line therapy for all patients with metastatic lung cancer was, chemotherapy alone. Fast forward to 2023, we have multiple approved targeted therapies as well as immunotherapy. So how do we select the best treatment for our patients? Is that, as we heard earlier, there are multiple different driver alterations. So truly a molecular revolution with many approved therapies. We're going to focus in on KRAS. So KRAS makes up about 30% of all patients who have lung adenocarcinoma. And KRAS mutations more commonly occur in Caucasian patients and those patients who have a former history of smoking. And when you look at the KRAS mutation population, of the KRAS mutant patients, KRAS G12C is by far the most common mutation, makes up about 42% of all KRAS alterations. So if you could do the math, and we'll do it together, 12% of all patients with non-small cell lung cancer diagnosed here in the US have a KRAS alteration or a KRAS G12C alteration driving their cancer. What's interesting to note here is if you go East Asia and China, for example, only 3 to 4% of patients will have a KRAS G12C. So these are really different populations with different prevalence of this mutation. So what is KRAS and what does KRAS do in the cell? So KRAS is really a molecular switch. And when it's turned on, the protein turned on, you can get constant signaling through that pathway, telling the cell to grow. When that switch is turned off, you don't get signaling through that pathway. And this is a critical pathway for cells in order for growth and proliferation and differentiation. And this is a really nuanced system where you have an on and an off state. You can imagine that thermostat in your house. And the way that that's mediated is by something called the GTP and GDP bound state. What happens in mutation or cancer is that the KRAS switch is always turned on. So specifically mutations in what we call codons 12, 13. So when we talk about KRAS G12, we're talking about the 12th codon. This leads to constitutive or continuous activation through this pathway.
Dr. Sabari.
Yes.
I'm so sorry. Your slides aren't progressing. We're still seeing the purple slide. If you could just please click down them as you go. Perfect.
Can I send you it and you just put it up?
You can if you think that would work better, or you can just do it that way.
All right. Can you see them now?
Yes.
All right. Sorry about that, guys. So KRAS mutations lead to this constitutive activation where you get constant signaling through this pathway, leading to proliferation and metastases. So how do we identify these alterations in our clinical practice? So lots of molecular testing is done in order to try to identify different alterations. So historically, we were using, immunohistochemistry and FISH, and these are really more outdated tests in order to do these types of testings. And what we really need is broad panel next generation sequencing. And Dr. Prushigal mentioned earlier, these are tests that will not only identify KRAS, but can identify all alterations using a limited amount of tissue. So really important when you're seeing your clinician, I want you to ask, or family members, ask if I'm having broad panel next generation sequencing. Some of the more outdated tests, such as FISH and IHC, do not have the ability to detect the KRAS alterations. There are some PCR-based assays that can do this, but really next-generation sequencing or broad panel next-generation sequencing is critical here. Here you can see a patient of mine with broad panel next-generation sequencing was identified to have a KRAS G12C alteration. And as we all look at these reports, we know they're complex, and there are other alterations that can co-occur. And we'll talk about some of those, such as STK11 and KEAP1 as well. So not only asking for the next generation sequencing testing, but then going over that report with your oncologist and asking them, what does all this information mean? I think it's critical to help guide your care. So we know that patients who have a KRAS mutation generally have a history of smoking and generally have many mutations in their cancer. Unlike patients who have EGFR mutations who may have never smoked, who don't have many mutations in their cancer and may not benefit from immunotherapy, patients with KRAS alterations do tend to benefit overall to immunotherapy. What we're looking at here is a very important study. It's a group of patients who had KRAS mutations compared to a group of patients who did not have KRAS mutations. So in blue, you see those patients who are KRAS wild type. So normal KRAS, no mutation. And you see that they survived at an equal rate to those patients who had KRAS mutations in red there. So telling us that patients with KRAS alterations may respond well to immunotherapy overall. However, we know that the story is a little bit deeper than that, right? We know that KRAS mutations are not all the same. You have different alleles. So we obviously have been talking about KRAS G12C, but patients can have KRAS G12D or G12V. And it's important to note what KRAS mutation you have. And then even within KRAS G12C, patients can have other co-mutations. And the other co-mutations are sort of like the genetic history of the cancer. What other mutations have accumulated and occurred over time? So some of the more common mutations that we see are STK11 and KEAP1. And I'll show you some data showing that patients who have more complex tumors or more heterogeneous tumors may not respond as well to immunotherapy alone. And we may need to think about this patient population somewhat different. So this is data that's somewhat old now, about 7-8 years, generated from MD Anderson, looking at a subset of patients who had KRAS mutations. But the team went a step further, not only looking at the surface alteration, but what other alterations did these patients have? And you can see that they defined 3 separate groups here. I want to focus in on this KL group on your left-hand side. The KL group are the patients who have a KRAS mutation, as well as STK11 and LKB1. And we know that, historically, these are enormously cold tumors, right? Tumors that are generally not responsive to immunotherapy. So when we look at the PD-L1 expression or programmed death ligand 1 expression is a marker on the surface of cancer cells that helps predict how likely immunotherapy will work. So when you look at the expression of PD-L1 in patients who have STK11 or LKB1, which is the protein, these patients tend to have very low expression levels of PD-1, which then correlate with potentially poor responses to immunotherapy. Now, why is the response to immunotherapy so poor in this patient population? We know that STK11 alterations suppress the tumor microenvironment, and really nicely shown in both a retrospective series and then in a prospective study looked at retrospectively. Dr. Scalidi's group here on the right-hand side were able to understand the response rates in patients who had this STK11 mutation versus those who didn't. So in red, if you see that in panel A, in red, the KL, those are patients who have KRAS mutations as well as STK11. The response rate, how common their tumor shrunk, was only about 10%. So that's pretty low. Whereas you look at the green, which is KRAS only, so those patients did not have any other KRAS alterations, K only, the response rates are in that 35-40% range. KP is a group of patients who had KRAS and P53, which interestingly respond very similarly to immunotherapy in those patients with KRAS alone. And when we looked at this also in a large prospective trial, Checkmate 057, very similar in those patients with KRAS alterations and STK11, the response rate was very low, sub 10%. And in those who had KRAS and P53 or KRAS alone, the response rates were far better. So not only is the response to immunotherapy worse in this patient population, we also know that the response rates are worse to chemotherapy. So this may be a poor prognostic sign as opposed to a predictive factor. Now, jumping into some of the KRAS therapeutics that we have available, it's really been a long road, and KRAS has been thought to be undruggable for many years. Here you can see the sort of discovery of the KRAS mutation back in 1967 and many negative trials. I have colleagues that have been involved in 30, 40 negative trials in this setting. Really wasn't until 2013, and I'll show you the really novel biology of how we are now able to target this alteration. More recently, in early 2021, we saw the approval of sotorasib, the first KRAS G12C inhibitor, and more recently, adagrasib, the second FDA-approved KRAS G12C inhibitor. So why has it been so difficult to target KRAS? So we know that KRAS is a very important node in a sequence or a pathway. And when you sort of try to target upstream of the pathway, you get bypass tracks or these sort of other avenues that develop where the tumor can still signal. So when we look at upstream inhibitors, right, as you see listed here, such as farnesyltransferase inhibitors, we're really unable to effectively block RAS. When we look downstream, right, of KRAS blocking maybe RAF or MEK or ERK, really also very limited duration of response. And when we've looked at directing KRAS inhibitors specifically to RAS itself, been very difficult to inhibit that pocket. And it wasn't until 2013 in Kevon Shokat's group in the West Coast where they were able to develop using medicinal chemistry, so tweaking the chemistry of a molecule to specifically block one residue, a cysteine residue, which is an amino acid in KRAS, to successfully block that pocket to prevent signaling through that. And this is really the story here, right? So we're now able to have a covalent inhibitor, a therapy that's able to bind the cysteine residue in this complex pocket and able to render this in the inactive state to prevent signaling through this pathway. So how is this started? And where are we now? I mean, we all know these memes. Going back to ASCO 2019, we saw data presented for AMG 510, now known as sotorasib. This was the last day of ASCO. Most people had already head home. And you see the initial response curve. So each one of these bars in this graph represent an individual patient, and bars that are downgoing represent response or regression in the tumor lesions. And what was really exciting to see is early on, we saw that 50% of patients had a radiographic response to this small molecule sotorasib. And really this opened the floodgates of many interesting and novel therapeutics in this space. So how is it going now? We now have 2 FDA-approved therapies with sotorasib with a response rate of about 37%, and more recently, adagrasib with a response rate of 43%. More recently, we've seen therapies divarasib as well as LY982, so very early on in development, doesn't even yet have a name, with similar response rates. So I think these are the early days of the targeted therapies in KRAS. We are nowhere near where we are in EGFR, where we're seeing response rates of 80%. We're still seeing response rates here in that 30-40% range. So more needs to be done in this patient population. Just like Dr. Prischkel showed us some data from ASCO, I want to show an updated data set from ASCO. This is JDQ443, which was just presented. Again, this is a KRAS G12C inhibitor. This would be the 6th one now in development, which showed a response rate overall of 57.1% in those patients who received the dose of 200 milligrams twice a day. It's important to note that this is still very early on in this trial, and we need to better understand how these medicines work. So what are some of the barriers to KRAS G12C therapy development for our patients? So we talked a little bit about heterogeneity in patients. Not all patients with KRAS alterations have just a KRAS alteration. They may have other alterations such as P53, KEAP1, or STK11, which may portend a poor prognosis. What's interesting to note is those patients do seem to benefit equally to the targeted therapies, whereas immunotherapy is really where they're not benefiting as well. You also can develop acquired resistance. So that's a selective pressure. When we treat with a KRAS inhibitor, we select for resistant clones or resistant alterations where the cancer learns how to outsmart the therapy. So it's important to note, just like in EGFR and KRAS, we have on-target point mutations. So different mutations in KRAS itself that prevent these medicines from binding. Those may be a little bit easier to target. What's more difficult to target are off-target resistance mutations or bypass track alterations. And we've seen quite broad heterogeneity here of, RET fusion, for example, RAF fusions, other MAP kinase alterations, even EGFR alterations in this patient population. So it's really a complex problem, and we need to start thinking about combination strategies. The other important feature here is CNS metastases or brain metastases, very common in this patient population. Upwards of 40% of patients with KRAS alterations will develop brain metastases, and we'll show some of that data. And then lastly, toxicity and tolerability. We know how important that is for our patients who we're taking care of in clinic. So these therapies do have some toxicity, primarily GI toxicity with diarrhea, some nausea, and some bloating. So effectively treating these. But more importantly, we're starting to see elevation in liver function tests, particularly in patients receiving sotorasib after receiving a PD-1 or PD-L1 inhibitor. And I'll show you some of the data where we're concerned about combining these agents together in the front line, where we may see toxicity, liver toxicity, when we combine a G12C inhibitor with PD-1 inhibitors such as pembrolizumab. So before that, I want to go over the confirmatory phase 3 study. These are studies versus docetaxel. Docetaxel is currently the standard approved therapy in the second line. So these are 2 studies, large studies, CodeBreak 200 and Crystal 12, Cobra 200, which has already been published. I'll show you the data, and Crystal 12, which is ongoing, where we looked at the activity of the G12C inhibitor versus a chemotherapy in the second line. And what was pretty disappointing in this study is that sotorasib had a response rate of only 28%. Far better than docetaxel at 13%, but clearly a drop from what we saw in the phase 2 trials of 37%. It's also important to note that the progression-free survival, how long someone's on the therapy before the disease progresses, was only 5.6 months. Again, better than docetaxel of 4.5 months, but still very short. And I think we need to do better for our patients. And then lastly, when we look at the overall survival, really the docetaxel, the chemotherapy, appeared to be better. And again, there could be reasons for this, such as crossover, patients then getting the sotorasib at progression. And this study was not powered. It wasn't intended to show differences between the survival in these populations. We talked about acquired resistance being really important. This is a patient of mine treated with a KRAS G12C inhibitor. You can see the mass in the left upper lobe, initially large and then regressed, but really quickly, after only about 4 months, had rapid progression or growth of the disease. And using liquid biopsy, and this is Dr. Awad's data, we've been able to show both point mutations in RAS, as well as these bypass track mutations that we may need to target. And in very important data showed by Dr. Skalides again from MD Anderson, in that phase 3 trial of sotorasib versus docetaxel, when you looked at those patients who had other point mutations or other RAS alterations, such as KRAS G13 or KRAS G12D, those patients did not derive any benefit from sotorasib. So again, looking at the whole report with your clinician is critical in order to guide best possible therapy. Here's a quick look at some of the intracranial activity that we've seen from adagrasib. This is a patient of mine and a patient treated in Boston at MGH, where we see good activity of adagrasib in the brain. And more recently, we published the updated data set. This medicine has a response rate of 42% in the brain, and we're seeing durable responses in the CNS. We have not yet seen any data from sotorasib or other therapeutics in the active, untreated brain metastasis patient population. So really critical thinking moving forward. So how do we move these therapies to the frontline setting? Well, why don't we combine them with immunotherapy, which is what we currently use in the first line? And the problem with sotorasib, which is the KRAS G12C inhibitor combined with pembrolizumab, is that we see very high rates of liver toxicity, upwards of 35% or so, which make it very difficult to use this combination. When we looked at the data of adagrasib in combination with pembrolizumab, this is from a smaller study and it's very early data, so take it with a grain of salt. We saw response rates very excitingly here of about 49-50%. And what was more important is that the toxicity rate was relatively low. So liver toxicity in that 5 to 10% range. More recently, at AACR, which occurred right before ASCO, we saw data from LY982, also in combination with pembrolizumab in the frontline. Very small subset of patients here, 9 patients, but a 78% response rate. More importantly, on the right, the treatment-related adverse events were low, and really no liver toxicity was seen with this combination. So in conclusion, KRAS G12C alterations are common. They occur about 12% of non-small cell lung cancer. They can also occur in other histologies, such as colorectal, but at much lower rates. And really broad panel next generation sequencing is critical for identification. We know that we now have novel small molecule inhibitors that block the cysteine residue. Sotorasib and adagrasib are FDA approved in the second line setting. So that's after progression on chemotherapy and immunotherapy. And we know that the response rates range between 30 and 50%. So we need to do better in this patient population. The progression-free survival, how long patients are on these medicines before the disease starts to grow, is still poor. It's only 6 to 7 months. So thinking about combinations and thinking about the development of the next generation KRAS inhibitors will be important. Resistance here is inevitable, and it's important to understand if you have resistance, just like in EGFR, what is the type of resistance? Is it a point mutation in RAS, an on-target mutation, or is it a bypass track or off-target resistance? And then lastly, toxicity and tolerability. I think we need to do better here as well. And we also need to do better with CNS activity. So with that, I want to thank you for your attention and your time. And sorry for the technical delays up front.
Thank you, Dr. Sabari. We are going to answer some questions from our audience at this time. So I'm going to bring back Dr. Prishigul and have you two, can you see the questions all right, Dr. Sabari?
Yes.
Perfect. I will have you two look at those and answer them for our audience. Let's see. Dr. Prishigul, would you like to start?
All right, I'll throw into you, Dr. Prishigul. All right, so how do you approach compound EGFR mutation? So we know that EGFR mutations, exon 19 or L858R, are common, but Dr. Prishigul, what if you see a compound mutation? Let's say, exon 19 and something else like, G719. And how common are these? Do you see these in practice? I think you're muted.
Wow.
Don't worry. Dr. Prishigul and I do this all the time. This is our first time on this platform, so we both apologize for the technical glitches.
Oh my God. It's actually my second, which is so embarrassing. So I should know better. Anyways, as I was saying, if you can't read lips, I love this question, Dr. Sabari. And I love it because there's no right answer. I think the more you look, the more you're going to find, right? So, and also the more you find, the more you have to look up and read about and teach. So compound alterations, I don't think we know the right thing to do with these patients yet. Unfortunately, there's no right answer. I can't tell you how many times I see something like this and I'm like, EGFR, 6, 7, whatever, all of this. And I'm on PubMed, I'm on UpToDate, I'm on, did anybody else have any experience with this? Because if I don't, you have to phone a friend, you have to ask somebody. And if there is no literature, there is no data out there, I have to go with standard of care for these patients.
Yeah, I agree. I think these compound mutations are difficult and to manage. And we know that the prognosis for patients with compound mutations is not as great as those who have single alterations due to the complexity of the tumor. And I think enrolling on a clinical trial here is critical. Another question, Dr. Prishigul, here is about T790M, and maybe explain that to us. Does that happen up front? And maybe there are some rare cases of that genetically inherited, or is that something more common that happens at resistance? And how do you think about that? And are you still seeing that in your practice?
Sure. So T790M is a gatekeeper resistance alteration that typically develops after you have progressed on, a second generation tyrosine kinase inhibitor like erlotinib or gefitinib. We're not really seeing T790M as much now because we're not really looking for it. And Osimertanive is the drug that really came about first because it showed activity against patients that harbored the T790M alteration. So I can't say I'm looking for this because before we had Osimertanive, if we saw that someone was progressing on erlotinib or gefitinib, we would say, oh, let's look for this T790M resistance alteration, and then we can give them OC. So now that we have Osimertanive approved in the frontline setting, we're not really seeing this, but we do see it from time to time. And I actually have seen some germline T790M alterations in patients that we're seeing more and more about. So I wouldn't say it's very common to look for this, but I do come across it. But it doesn't really excite me that much. It doesn't really change my practice as of now.
Yeah, I would agree. Another great question here is on P53, co-alteration. And I'll take this one. We talked about KRAS and co-alteration. There's lots of discussion now, right, Dr. Prishigul, about EGFR and co-alterations as well. And this is uniquely different from a compound mutation, right? What Dr. Prishigul was just talking about are having two mutations driving the cancer. These are potentially passenger alterations like P53, which may not be present in every single clone of the cancer, but may be present in a dominant clone of the cancer. And we know that the prognosis for patients who have co-alterations in P53 may not be as good as those who don't. So the question here is, how do you think about treatment of a patient with a P53 and an EGFR mutation? Well, we have great clinical trials in this setting. Dr. Helena Yu at MSK has a study open. We have it open at our site as well, where patients can get osimertinib, a third-generation EGFR TKI, and if they're still shedding the clone 4 weeks out with plasma next-generation sequencing, we then will add chemotherapy. But curious, Dr. Prishigal, in the future, do you think we'll be doing more for this patient population, such as the FLORA data, chemotherapy, plus the osimertinib, or maybe even amivantamab, the EGFR and c-MET bispecific, plus lazertinib?
So I think the first thing is awareness and understanding that you need to look for TP53 and RB loss in patients that harbor EGFR alterations, because sometimes you might get your next generation sequencing report back and you might see EGFR exon 19 deletion and TP53, oncogene mutation, right? And then you might just think, oh, it's just, TP53, whatever. But that should send an alarm off in your head to ask your tissue to be sent for immunohistochemistry to see if you have loss of RB. Because if you have loss of your function of RB, then we know you are more at risk to develop what we call a resistance alteration of small cell transformation, where your non-small cell changes to small cell. So I fully believe in this study. Obviously, Dr. Helena Yu is one of my amazing colleagues and mentors, and yours as well, Dr. Zabari, I know. And I've enrolled many patients on this study to see if it makes a difference. I'm hoping that awareness is going to lead to change here, that we won't even need to have a clinical trial, that the second we see TP53 and EGFR, we will hunt for that RB and we will put these patients on OC plus something. I do feel a little bit more strongly about adding a small cell regimen in there somewhere. I'm concerned that if we just gave them AMI and lazertinib and OC, it may not hit that small cell clone. So I do think having, platinum etoposide in there to just pack a little bit more punch should be given. What are your thoughts?
It's important to note that we don't really have prospective data yet in this patient population. So I think getting osimertinib alone is never wrong. But I agree with you, if you're starting to see emergence of resistant clones, and so that's the difference between upfront treating and versus down the road resistance, I agree it's of concern. Now, when we talk a lot about P53 and RB1, what we're talking about are genes that suppress tumors. These are tumor suppressor genes and very difficult to target with targeted therapy, whereas EGFR is an oncogene, and that's something that we can actually block or inhibit. So I agree. I think we're going to need more data and better therapeutics, particularly those for those patients who develop these high risk sort of, resistance pathways, and, very tough. I don't generally use, platinum and etoposide yet in patients who just have an RB and a P53 mutation or a loss, unless they have a true histologic transformation. It's interesting, preclinically, you do see some small RB1 clones, and we don't know if that's dominant in the tumor. So really a lot of unknowns here and a lot more investigation needed. I want to turn it back to you, Dr. Prishigal. Someone asked a really good question about CNS, and you mentioned that when you see CNS sort of cohorts open for patients with EGFR on trial, you get excited. I get excited as well. This is a significant unmet need for our patients. So what's your opinion on this pulse dose of afatinib, a second-generation EGFR TKI, and osimertinib, a third-generation EGFR TKI, specifically for patients who have leptomeningeal disease, so cancer involving the lining part of the brain? And so comment on that, and then also, what are some other strategies that you've looked into for leptomeningeal disease in this setting?
So as I had mentioned, patients that harbor EGFR mutations have a very high propensity to develop brain metastases, whether at diagnosis or whether down the line their treatment course. So pulse dose or higher dose or even double dose of these tyrosine kinase inhibitors has been explored. I know there was some data that was presented at ESMO a couple years ago looking at osimertinib given at the dose of 160 milligrams a day instead of the standard 80 milligrams a day. And typically between afatinib and osimertinib pulse dosing, I typically tend to lean a little bit more towards the osimertinib pulse dosing, and that's simply because toxicity. Afatinib alone compared to osimertinib is a much dirtier drug. The diarrhea is legit. I don't have to tell you that. If you've been on it, it's awful. And if we have a drug that's also efficacious in this setting and has better toxicity, why not try that? So that's my reasoning there. I definitely have used what we affectionately call double dose OC before for my patients that have leptomeningeal disease, or for someone that perhaps is on osimertinib at 80 milligrams and has just progression in the brain. And maybe is not interested in chemotherapy, not a candidate for radiation because they've previously received radiation, older and, not interested in IV chemo, or doesn't meet criteria for a clinical trial. So I would definitely believe double dose OC is effective for the right patient, but it is more toxic. And it is definitely it's not easy.
Yeah, I agree. I think, CNS metastases, leptomeningeal disease remains a really high unmet need. And we are looking at therapeutics that have, better CNS penetration, but really it's targeting that resistance clone in the CNS as well. Osimertinib, right, a third generation EGFR TKI has great CNS penetration, but if you lose activity of the drug, you really need to think about a different strategy. So moving to amivantamab, somebody asked a question about the Chrysalis trial here. The Chrysalis trial is a study which looked at amivantamab, a c-Met EGFR bispecific, and there are some cohorts where patients received that in combination with lazertinib. Any updates on this study, and what is the efficacy of these two drugs in combination compared to OSI? Any ongoing studies in this space?
Sure, yes. I know I didn't really talk about EGFR exon 20 alterations in this setting, but amivantamab is a bispecific antibody, as I had mentioned, EGFR and MET. It's an infusion, and lazertinib is a pill. And I do think that there is some exciting data from the Chrysalis study. I think that the amivantamab alone, as we know, does not have great CNS penetration or penetration into the blood-brain barrier. However, lazertinib, a third-generation tyrosine kinase inhibitor pill, does. So the thought is that the combination of these two could be like a perfect marriage or best friends, that you have the amivantamab that hits the MET and the EGFR, and you have the lazertinib that penetrates into the blood-brain barrier. And the two of them are thought to function quite well. And I think, obviously the jury is not out yet in regards to this, but I think there is some promise here. I am enrolling patients in this study. I believe in this study. I think we need something. We need something post-OC. And we need something to help those patients that have very recalcitrant or resistant CNS disease. And if they're progressing on OC, maybe lazertinib plus amivantamab is the right answer. Maybe not, but I think we need to try something. Dr. Sabari, what are your thoughts?
Yeah, no, I agree completely. I think that, in the second line setting post osimertinib, I really like to try to utilize other targeted therapy strategies. Bispecifics, for example, are exciting. There are also ADCs that you had mentioned, the patritumab deruxtecan, which targets HER3, as well as has a chemotherapeutic warhead. You call it a Trojan horse. I love that. It's also really important to think about maybe we can prevent the emergence of some of these resistance mutations by moving these therapies up front. So we had a question earlier about T790M, which was the most common gatekeeper resistance mutation to first and second generation EGFR inhibitors, but we don't see that in the clinic anymore. Really, it does not exist because, it's really covered by the third generation EGFR TKI osimertinib. So what are some of the resistance mechanisms? You mentioned MET and C797S. So how do we target those specifically? It could be very interesting to look at amivantamab and lazertinib in the front line. And there is an ongoing study now, the Mariposa trial, comparing lazertinib versus osimertinib versus lazertinib as well. So it'll be interesting to see that data. There's also an ongoing study of osimertinib plus the ADC, patritumab deruxtecan. So that'll be really, really important. And I do think that, as great as a drug as osimertinib is, I don't think it's going to be utilized in the future as a single agent. I think, in oncology progress, we need to build upon what we currently have, right? So, 19, 20 months before progression on a drug is not enough. We need more for our patients.
I agree. And I think just to kind of put another plug for a study at MSK, Dr. Helena Yu is the global PI for Orchard, which is a study that looks at patients that have progressed on frontline osimertinib. So there's 9 cohorts, and based on, if you have progression, we look for any of those resistance alterations. Do you have MET amplification? Did you develop a BRAF alteration? Do you have small cell transformation? Do you have squamous cell transformation? Any of those. And based on what your resistance mechanism is, you get put into a cohort that has that new targeted therapy involved in it. So you're basically put on treatment based on your resistance mechanism. I think it's a very well-designed study. It makes sense. And it's looking to push the envelope a little bit more. So clearly, as Dr. Sabari said, we have lots of options of clinical trials in the post-OC setting, but there's no right answer. I do want to actually volley a question back at you in the KRAS space, if that's okay, one that caught my eye. In your opinion, does KRAS in someone that has no smoking history, would they be sensitive to immunotherapy in this setting?
It's very interesting. We rarely see KRAS in someone with a no smoking history. It's less than 1% of the patient population. For example, if you see a KRAS G12D mutation or E mutation, those patients who are never smokers are not generally responsive to immunotherapy. They have lower mutational burden and lower neoantigen load. So their tumor, actually, the way I explain it to patients, looks very similar to normal tissues in the body. As opposed to someone who's smoked for many years, that tumor may look very different from the normal tissues in the body, and revving up the immune system would actually be more helpful. So a patient who never smoked, who developed a KRAS mutation, I would more focus on targeted therapies. And there are novel targeted therapies that we talked about for G12C. What I didn't talk about today is that there are also therapies in the clinic now, investigational, development on trials for G12D, as well as these pan-RAS inhibitors that are really exciting. So, definitely reach out to your oncologist and ask them about what trials are available in this space. But I would shy away from immunotherapy. Curious, Dr. Priscigal, your thoughts on never smoker, KRAS mutation, what would you do?
I mean, I echo exactly what you said. I think it's very rare to find a KRAS alteration in somebody that has never smoked. And I think my first gut would be, let's make sure this is a lung cancer and this is not a metastasis from your gut. And this is not a different primary. Because KRAS alterations are seen in colon cancers. They're seen in stomach cancers, pancreatic cancers, a lot of GI malignancies and other malignancies. So that's, anytime someone has something that just kind of smells fishy, I always make sure you up to date on endoscopy, colonoscopy, pap smear, mammogram, all the age appropriate cancer screenings. Other than that, I think targeted therapies are really exciting in this space. We are, sotorasib, and adagrasib came about, and we talked about drugging the undruggable, and now this orphan child has more of a home. And while these drugs are not approved in the frontline setting, I would look for clinical trials. That's where the answer is, I think. So I would talk about trials, and I would make sure that there isn't a secondary malignancy.
Yeah, I couldn't agree more. There's an interesting question here about liver toxicity in the KRAS G12C space. And, when we develop new medicines in the clinic, we oftentimes see both on-target toxicity as well as off-target toxicity. What does that mean? On-target is a tox that we're actually hitting the target. A great example of that is an EGFR, right? When we block EGFR, we see some skin tox, some rash, and we also see some diarrhea. In KRAS, we're not sure 100% if the liver tox is on target or potentially off target, or maybe even immune mediated. So what's interesting to note is early on when we were developing sotorasib and adagrasib, we saw some liver toxicity in about 5 to 10% or so of patients, where we give the therapy and we see the liver tests rise and we have to dose reduce the medicine. And we always worry about dose reduction because of efficacy. When we then started really treating a lot of patients with sotorasib, we noticed the toxicity of the immune system being active post receiving a PD-1 inhibitor. So I'm not sure, Dr. Prichko, have you seen this in your practice? Elevated liver tests post, first generation or I guess we can call them first generation KRAS inhibitors, but giving a KRAS inhibitor post immunotherapy.
So I definitely have seen hepatotoxicity while you're on sotorasib or adagrasib, and also in this setting. It's difficult to say if it's from the immunotherapy or if it's from the targeted therapy or what it's necessarily from, which is why the JDQ 443 study that was presented at ASCO really caught my eye, because they had sort of focused on looking just at this about hepatotoxicity in regards to immunotherapy when you've been exposed to sotorasib. And I think that they actually found that that this combination with JDQ 443 and chemo IO was actually safe and did not have much hepatotoxicity. So this is something that I don't know if you came across this data, but I actually thought it was pretty exciting. And
So yeah, I agree with you. This is a really tough space in that when we try to combine sotorasib with immunotherapy for people newly diagnosed with lung cancer, really was not possible due to liver toxicity, right? About a third of patients were developing really high rates of transaminitis, which is an elevation in your liver numbers. Again, not fatal, but something that we need to dose reduce the medicines for, and even put patients onto high doses of steroids. And we do think that this is immune mediated. So I would recommend, when you're seeing a patient with a KRAS alteration, or if you're the patient with a KRAS alteration, have your liver test checked within the first 10 days to 14 days after starting, and routinely thereafter. It's not a medicine that you can just start and then just say, hey, see you back in 3 months. The other thing that's interesting is when we looked at adagrasib in combination with immunotherapy, it seemed to be relatively safe. So the rate of high-grade liver abnormalities were low, less than 10%. And we also saw the LY982 therapy showing that the rate of liver toxicity was low. So that'll be really important moving forward of how can we use these therapies safely in combination without causing toxicity for our patients. Do you want to talk about uncommon EGFR mutations? There are a couple of questions here. I see about exon 18 and some on exon 20. How do you think about those as different from exon 19 or exon 21? Or are we talking about the wrong thing when we talk about exons? Should we be talking more about functional status? What are your thoughts?
So I also do want to be mindful of the time, because I think we might
What
be
time?
running over.
Yes.
Oh, yeah.
Thank you so much. I was just getting ready to jump in. You're fine. I love that you all
Nobody told
are.
me we were moderating times, but what time are we over now?
Oh, we're fine. We're right where we need to be. But I wanted to
Perfect.
thank you both for joining us. That was very insightful and wonderful to have you both with us on this. I would like to let our audience know that we will be having another short break at this time, and you're welcome to join us back here on the main stage at 2 p.m. Eastern, 11 a.m. Pacific, for more presentations, starting with Ivy Elkins, who is a patient advocate. So again, thank you all so much for being here. It was wonderful to see you.
Thank you so much. This was great.
Thank you for having us.
Thanks.
Welcome back, everybody. Hope everyone had a good lunch or brunch or whatever time zone you're in. It really is my honor and privilege to introduce our next speaker. Ivy Elkins has been in the lung cancer community a long time, a strong advocate, a survivor. She lives in the Chicago suburbs with her husband, Ben, and her 2 teenage boys. She's been a dedicated advocate for lung cancer research, has been a reviewer in DoD, AACR, ASCO ACR methods, as well as the program committee for ISLC's Chicago multidisciplinary meeting. She really is a gem in terms of sharing her patient perspective, both with the media as well as pharmaceutical companies, to advocate for patients. She was one of the founding members of the EGFR resistors patient group, and she recognizes that new treatments are desperately needed for patients who develop resistance to currently approved targeted therapy medications, as you heard about from our earlier speakers. It's her hope that patients will join forces with EGFR resistors in order to become a strong voice to encourage new research and clinical trials in the field. And so without further ado, I want to hand this off to Ivy. Thank you so much for joining us. Ivy, you have the screen share going?
Yes. Give me 1 second to get that set.
And can maybe someone on the ops team, if Ivy needs help, can help her out. Thank you.
Absolutely. Ivy, if you're having any trouble sharing, let me know. I do have your presentation and I can share it for you if needed.
Can you see that?
No, we don't see your screen. Hold on.
That might be for the best because I have it up on the screen.
Sure, I can go ahead and share and bring that up. You just need to tell me when you would like
wait
me
a sec.
Oh, okay.
I think I just figured it out.
Okay. Perfect.
Can you see it now?
Yep, that looks great.
Perfect. Well, thank you, everyone. Thank you for the introduction. As mentioned, I'm Ivy Elkins, and I'm a patient advocate who has been living with stage 4 lung cancer for almost 10 years. I'm very honored to be part of the Targeted Therapies Forum and talk with you today about the patient experience and the importance of advocacy in lung cancer. I'll start by telling you a little bit about myself. I live in Evanston, Illinois, just north of downtown Chicago. I've been married for 27 years and have 2 sons, currently 20 and 22 years old. When I was diagnosed with stage 4 lung cancer in December 2013, my boys were 10 and 13 years old. The first picture up on the screen was taken just about 1 month prior to my diagnosis. In the middle of 2013, I started having some pain in the left side of my neck and difficulty straightening my elbow. I went to my primary care physician, and he diagnosed me as having an overuse injury, probably due to my brand new iPad and an addiction I had developed to Candy Crush. I had an X-ray of my elbow, which was clear, and an MRI of my neck, which showed just mildly degenerating discs, consistent with my age of 47 at the time. My doctor then recommended that I go to physical therapy. So over the next 6 months, I visited 2 different physical therapists, 2 different orthopedists, a rheumatologist, and tried numerous exercises and cortisone shots for my elbow. It just didn't respond to normal treatment and kept getting worse. So finally, my second orthopedist ordered an MRI of my elbow, and the MRI showed a mass on the bone, which was impacting the joint. I then visited an orthopedic oncologist who took 1 look at me, said he was 95% sure the mass was benign, and scheduled a biopsy to double check. Unfortunately, the biopsy results came back and it wasn't benign. It was adenocarcinoma, which I then learned was a type of cancer that doesn't originate in the bone. I had a PET scan, and it turned out that the origin of the cancer was a tumor in my right lung that had spread to my bones, areas in my elbow, neck, ribs, and pelvis. And a subsequent brain MRI showed that I also had 8 small lesions in my brain. I can't tell you how much I was shocked and devastated. I had no idea that I could even get lung cancer. It wasn't on my radar screen. I didn't have any of the traditional side effects that I associated with lung cancer, such as coughing, wheezing, shortness of breath, or anything like that. I didn't know then what I know now, which is that anyone with lungs can get lung cancer. And I also didn't know that not all lung cancer is the same and is not treated the same. Fortunately, I found a fantastic thoracic oncologist. I'm pictured up there with her, Dr. Josie Patel. And I had biomarker testing and found out that my lung cancer is driven by a mutation in an EGFR gene. I've been treated with oral targeted therapy these past almost 10 years. My first medication worked for close to 3 years, and very soon after I started treatment, my brain lesions disappeared, bone healed.
Welcome back, everybody. Hope everyone had a good lunch or brunch or whatever time zone you're in. It really is my honor and privilege to introduce our next speaker. Ivy Elkins has been in the lung cancer community a long time, a strong advocate, a survivor. She lives in the Chicago suburbs with her husband, Ben, and her 2 teenage boys. She's been a dedicated advocate for lung cancer research, has been a reviewer in DoD, AACR, ASCO-ACR methods, as well as the program committee for ISLC's Chicago multidisciplinary meeting. She really is a gem in terms of sharing her patient perspective, both with the media as well as pharmaceutical companies, to advocate for patients. She was one of the founding members of the EGFR resistors patient group, and she recognizes that new treatments are desperately needed for patients who develop resistance to currently approved targeted therapy medications, as you heard about from our earlier speakers. It's her hope that patients will join forces with EGFR resistors in order to become a strong voice to encourage new research and clinical trials in the field. And so without further ado, I want to hand this off to Ivy. Thank you so much for joining us. Ivy, you have the screen share going?
Yes. Give me 1 second to get that set.
And maybe someone on the ops team, if Ivy needs help, can help her out. Thank you.
Absolutely. Ivy, if you're having any trouble sharing, let me know. I do have your presentation and I can share it for you if needed.
Can you see that?
No, we don't see your screen. Hold on.
That might be for the best because I have it up on this.
Sure, I can go ahead and share and bring that up. You just need to tell me when you would like
wait
me
a sec.
Oh, okay.
I think I just figured it out.
Okay. Perfect.
Can you see it now?
Yep, that looks great.
Perfect. Well, thank you, everyone. Thank you for the introduction. As mentioned, I'm Ivy Elkins, and I'm a patient advocate who has been living with stage 4 lung cancer for almost 10 years. I'm very honored to be part of the Targeted Therapies Forum and talk with you today about the patient experience and the importance of advocacy in lung cancer. I'll start by telling you a little bit about myself. I live in Evanston, Illinois, just north of downtown Chicago. I've been married for 27 years and have 2 sons, currently 20 and 22 years old. When I was diagnosed with stage 4 lung cancer in December 2013, my boys were 10 and 13 years old. The first picture up on the screen was taken just about 1 month prior to my diagnosis. In the middle of 2013, I started having some pain in the left side of my neck and difficulty straightening my elbow. I went to my primary care physician, and he diagnosed me as having an overuse injury, probably due to my brand new iPad and an addiction I had developed to Candy Crush. I had an X-ray of my elbow, which was clear, and an MRI of my neck, which showed just mildly degenerating discs, consistent with my age of 47 at the time. My doctor then recommended that I go to physical therapy. So over the next 6 months, I visited 2 different physical therapists, 2 different orthopedists, a rheumatologist, and tried numerous exercises and cortisone shots for my elbow. It just didn't respond to normal treatment and kept getting worse. So finally, my second orthopedist ordered an MRI of my elbow, and the MRI showed a mass on the bone, which was impacting the joint. I then visited an orthopedic oncologist who took one look at me, said he was 95% sure the mass was benign, and scheduled a biopsy to double check. Unfortunately, the biopsy results came back and it wasn't benign. It was adenocarcinoma, which I then learned was a type of cancer that doesn't originate in the bone. I had a PET scan, and it turned out that the origin of the cancer was a tumor in my right lung that had spread to my bones, areas in my elbow, neck, ribs, and pelvis. And a subsequent brain MRI showed that I also had 8 small lesions in my brain. I can't tell you how much I was shocked and devastated. I had no idea that I could even get lung cancer. It wasn't on my radar screen. I didn't have any of the traditional side effects that I associated with lung cancer, such as coughing, wheezing, shortness of breath, or anything like that. I didn't know then what I know now, which is that anyone with lungs can get lung cancer. And I also didn't know that not all lung cancer is the same and is not treated the same. Fortunately, I found a fantastic thoracic oncologist. I'm pictured up there with her, Dr. Josie Patel. And I had biomarker testing and found out that my lung cancer is driven by a mutation in an EGFR gene. I've been treated with oral targeted therapy these past almost 10 years. My first medication worked for close to 3 years, and very soon after I started treatment, my brain lesions disappeared, bone healed, and grew back in my neck, elbow, and other areas, and the main mass in my lung shrank significantly. In 2016, I had some progression in my original lung tumor, so I had repeat biomarker testing and began a new targeted therapy for a secondary mutation called T790M that I had developed. I was fortunate to have further shrinkage in my original tumor. In early 2020, I had a PET scan that showed the only area of identifiable cancer I still had in my body was the original primary tumor in my upper right lung. So I had a lobectomy to remove my upper right lobe. I was considered NED, which means having no evidence of disease, for a lovely 2.5 years. But last summer, unfortunately, cancer started growing again in my lungs, and I'm now on a combination therapy. I take 2 different kinds of targeted therapy pills for the BRAF fusion I developed, along with my original EGFR mutation. So why am I telling you my whole story? I'm telling you my story for a few reasons. I'm guessing some of you might identify with parts of my patient journey, and I want you to recognize that you are most definitely not alone. I also want to underline the importance of research. I'm only alive today as a result of recent developments over the past 5 to 10 years in molecular testing and targeted therapies. I consider my relationship with my oncologist to be a partnership, and we work together to make the best decisions possible for my treatment at any given time. I've been incredibly fortunate to see those two little boys in that first picture up on your screen grow up. One just graduated from college, as a matter of fact, last month, and the other will be entering his junior year in college in the fall. I started to get involved in patient advocacy when I learned about the Longevity Foundation's work from a friend I met soon after my diagnosis. Some of you may know her, super advocate and patient Jill Feldman. I found it astounding how little I knew about lung cancer before being diagnosed, and felt that it was important to me to share my experiences with others. It took me a little while post-diagnosis to feel ready, but once I was, I began to meet others in the lung cancer community through attending local longevity events, and later by traveling to the annual Longevity Hope Summit for patients and caregivers in Washington, D.C. I started telling my story, fundraising, and supporting other patients. I found that I wanted to learn more about the science of lung cancer and keep informed about research and development efforts. So I started reading journal articles and attending conferences like ASCO, which is the American Society of Clinical Oncology, which is held in my hometown of Chicago. Now, my background is definitely not in science. I have an undergrad degree in English and an MBA in finance. However, as I started to learn more about research, I realized that this was the area where I wanted to focus my advocacy efforts. I knew I was alive because of research, and I wanted to share my perspective in order to help scientists better meet the needs of patients like myself. Now, let me back up just a little bit and talk about what it means to be an advocate. As I mentioned before, it took me a little time to feel ready to go out, meet others living with lung cancer, and share my story and perspectives publicly. I had to get used to being a patient before I could become an advocate. As a patient, I started to learn about my disease, but focused mainly on myself and my treatment. I felt very emotional about my diagnosis, which is completely normal, and I couldn't really separate these emotions from any decisions I made. I couldn't even talk about my diagnosis without crying. I was really still grieving the difference between what I had expected to be my life and my sudden diagnosis with stage 4 lung cancer. However, as I started getting more involved in gathering knowledge, I realized how much hope there is today for those of us living with lung cancer. There has been an explosion of new treatments for all stages of diagnoses, and there is so much exciting and promising research and developments on the horizon. I wanted to be part of this. As I developed more in-depth knowledge about lung cancer, I began applying for advocacy programs. I'll give you a few examples a little later that can get me started in focusing on influencing research and representing the greater lung cancer community. Each one of my advocacy activities has built on the others and given me increasing amounts of visibility and credibility. I didn't become an involved advocate overnight, and I still do a ton of learning along the way. I'd like to make sure everyone knows that there are many different ways to be a lung cancer advocate. If this is something that interests you, it's important to find the way that gives you energy rather than drains you. You should advocate in a way that you enjoy, that uses your strengths, and that fulfills you. There are really no requirements in advocacy. You can do as much or as little as is possible for you, given your other priorities and needs in life. Many people advocate for overall lung cancer awareness and education. As I mentioned earlier, I, like many others, didn't even have lung cancer on my radar screen when I was diagnosed. There's a huge need to educate the public that anyone with lungs can get lung cancer. There are a lot of ways to do this, including sharing your story, participating in Lung Cancer Awareness Month activities in November, and becoming part of the White Ribbon Project. You'll see a picture of a group of us on this slide holding giant white ribbons. And to learn more about the White Ribbon Project, you can check out their website, which is www.thewhiteribonproject.org. You can read about how anyone can be an advocate by ordering a white ribbon, they're free, and displaying or sharing it. Others like to support fellow patients and caregivers. This is very important because no one should feel alone with a diagnosis of lung cancer. Longevity has a fantastic program called Lifeline Support, where a patient or caregiver can be matched with someone similar to them for direct one-on-one support and assistance. There are other organizations that have similar programs, and this support can be in person or virtual, depending on your preferences. Fundraising is another way that many patients and caregivers show support for I'm sorry, I lost my place. Fundraising is another way that many patients and caregivers show support for lung cancer research and development. As many of you know, lung cancer is not as highly funded by the federal government as many other cancers, and as a result, depends on nonprofit and other private sources of funding. Speaking of the federal government, some advocates participate in political advocacy, where they work to increase the funds that the federal government allocates to lung cancer research. Political advocates may visit DC, storm the Hill, and participate in other lobbying efforts. Go2 Foundation holds an annual Lung Cancer Voices Summit that focuses on this type of advocacy. Locally, there are often other opportunities to participate in government efforts, local efforts, to improve laws for topics such as biomarker testing in many states. Last but not least is research advocacy, my area, my main area, where advocates work with scientists, researcher oncologists, pharmaceutical companies, and industry members in order to share the patient perspective and make sure research meets patient needs. One role of research advocates is to act as a liaison between the patient community and scientists. We inform and educate the patient community about developments in clinical trials. Often what this means is that we take a very scientific topic and try to help describe it in more easily understandable lay language so that it's more accessible to people without scientific backgrounds. If you've ever spent time on clinicaltrials.gov looking for a clinical trial or attempting to read an article from a medical journal, you know how difficult the language used can be and how difficult some of that structure can be. So advocates really do a lot in order to improve and make it possible for people without a medical background to understand these things. Advocates do things like reviewing clinical trial protocols and informed consent documents to make them more understandable and patient-friendly as well. In order for researchers to get the funds for their research, they typically need to apply for grant programs. These grants can be from the government or from private funders. Advocates help evaluate these grant applications to see if they actually will have a significant impact on patients and are deserving of being funded. We want projects to be funded that will help us move forward with understanding and treatment of lung cancer, not just interesting science. In fact, many organizations that give grants are now mandating that patients be involved in this type of review process. Some research advocates participate in various regulatory bodies, such as institutional review boards and data safety monitoring boards, to make sure that patient rights are not being compromised for the sake of research. Others share patient perspectives on research through participating in cooperative groups, SPORs, and pharmaceutical advisory boards. Cooperative groups are supported by the NCI and are made up of researchers, cancer centers, and advocates working together to develop clinical trials. There are currently 4 cooperative groups in the United States that deal with adult oncology. NCI-funded SPORES are cancer center-specific academic cancer centers and bring together multidisciplinary experts within that center to collaborate on research projects. SPORE stands for Specialized Program of Research Excellence. Advocates working with these type of groups can often share patient perspectives with large numbers of researchers at one time who are on the cutting edges of research. Last but not least, research advocates can collaborate directly with scientists to develop projects and trials to benefit patients. A number of groups founded in the past 10 years focus on patient-directed research in this way, and I'll talk a little bit about this shortly. I'm just going to highlight a few of the first research advocacy opportunities that I participated in order to give you some ideas of how you might want to get started if you're interested in research advocacy. The DoD, which stands for the Department of Defense, funds medical research on a variety of disease states, including lung cancer, and puts together panels of scientists and patient advocates to review the proposals that are submitted. Patient advocates who participate on these panels are called consumer reviewers, and they review the proposals for potential patient benefit, not scientific merit. You do not need to have any kind of scientific background to participate. Consumer reviewers need to be recommended by an advocacy organization. I was recommended by Longevity when I started doing this. Fill out an application and interview with someone from the program. I was placed on my first panel as a consumer reviewer in 2016 and have participated in 8 panels total now. It's a really exciting program because as a patient advocate, you get to work directly with scientists to discuss the pros and cons of various proposals that are up for possible funding. Often, there are things that we as patients bring up that scientists haven't really thought about because they're just so deeply entrenched in the science itself. Everyone gets an equal vote on each proposal, so consumer reviewers' opinions are as important as those of the scientists on the panel. While it's a significant time commitment reading all of the assigned proposals and writing comments, not to mention dedicating time for the panel discussions, the DoD is really one of my favorite research advocacy activities. I always learn so much through reading the proposals and participating in the discussions. I've made many valuable connections with researchers, and I truly feel respected for my opinions when serving on a panel. Important skills to have for this program include the ability to express your opinions comfortably, both in writing and verbally, and in a professional manner that really focuses more on collaboration than confrontation. It's also critical to be able to step back from your own personal situation in order to advocate for the best science for the lung cancer community as a whole. Next, I'd like to mention an AACR program, which I participated in after doing my first DoD panel. AACR stands for the American Association of Researchers during that first DoD panel. They mentioned it and suggested that I might want to consider applying for it. I decided to do that and ended up completing an application and getting recommendations both from one of these researchers and from Longevity. AACR focuses on scientific cancer research and has a number of conferences throughout the year, including an annual meeting. The Scientist Survivor Program provides a special additional track at AACR for patient advocates with separate lectures, small group workshops, and tons of opportunities to connect and ask questions of researchers. It was a great experience because I got to meet and work with advocates from all different cancer types, which was a fantastic way to make new connections. I also learned how to create and present a scientific poster, got to attend special receptions, and learned tons, all in addition to attending the AACR annual meeting. As a result of participating in SSP, I made many contacts in the research world, which led to other advocacy opportunities. Again, it was a significant time commitment, which included attending pre-conference calls, developing a poster, and participating in work group meetings and presentations. Important skills to have for this program included a strong interest in collaboration across backgrounds, plus a certain degree of confidence in order to take full advantage of the networking opportunities, many of which take place informally at receptions. I've now been part of the program 3 times, twice as a participant and once as a mentor. Other conferences, in addition to AACR, have programs like this as well to encourage and support research advocacy. A great program that is relatively new is the IASLC's STARS program. I've only participated in this program as a mentor since it didn't exist when I first got involved in research advocacy. The STARS program focuses specifically on developing research advocates for lung cancer and teaches participants both the science they need to understand in order to be an effective advocate and ways to improve their communication skills. Those who participate in STARS learn from each other, subject matter experts, and mentors who are more established research advocates in the lung cancer community. The program culminates in either virtual or in-person attendance at the World Conference on Lung Cancer, where participants can put their new skills into action. Then they take these skills back to their communities with plans for future advocacy work. There are also opportunities to advocate for the specific type of lung cancer that you might have. As I mentioned earlier, I learned that not all lung cancer is the same and is not treated the same when I was first diagnosed. As you now know as well, there are many different types of lung cancer. As you can see from the pie chart on the left, lung cancer is first broken down into 2 main types, non-small cell and small cell. Adenocarcinoma is the most prevalent type of non-small cell lung cancer. And recent research has shown that there are a large number of biomarkers that can drive adenocarcinoma. You can see some of these in the pie chart on the right. Different biomarkers mean different treatments, precision medicine treatments that are directly targeted to the genomic changes that cause cancer, like my EGFR mutation. Biomarker testing and therapies targeted to these biomarkers have allowed people with lung cancer to live longer and better in the past 10 years or so. As a result, they've been able to take a larger role in advocating for themselves and others. Advocates have formed patient groups for many of the biomarker-driven cancers on the pie chart you saw on the previous slide. These groups are usually patient-run and determine their own agendas, focusing on what they feel are unmet needs in their subset of lung cancer. However, they all have in common what they offer patients and caregivers. This is hope, support, education, empowerment, and connections. Many people who join these groups have never met another person living with lung cancer, let alone a tribe who shares their specific type of lung cancer. Some of the groups also participate in the patient-driven research that I mentioned earlier. This is very important because as patients, we have critical information to share and a unique perspective. Patient-driven research can help scientists learn about a number of things, including disease biology. They can help them develop and test new treatments, identify best practices, generate ideas for new studies, and support regulatory approvals. I'm just going to talk a little briefly about one of these groups because I have personal knowledge. And this group is the EGFR resistors, which I co-founded with 6 other patients and 1 caregiver in the middle of 2017. We decided that we wanted to build a community of patients and caregivers who share knowledge, provide support, and work to accelerate research with the goal of improving outcomes for EGFR positive lung cancer. We created a closed Facebook group for patients and caregivers only and communicate with the broader EGFR positive community through our website, Twitter, and Instagram. We have a monthly newsletter that anyone can sign up for on our website. So I encourage any of you to do so if you're interested in learning more about our work. Please also follow the EGFR resistors on social media. Our initial group of 7 founders has grown to approximately 5,000 members from over 95 different countries. We have created many collaborations in order to fund and accelerate research, including a patient-driven partnership with Longevity called Project Priority to study the real-world experience of those living with EGFR-positive lung cancer. This includes unmet needs, areas for improvement in diagnosis and treatments, and patient concerns. Priority stands for the Patient-Reported Initiative on Resistance Incidence and Treatment Study and was made up of a series of questions to our members. Based on our findings from Project Priority, we've collaborated with both Longevity and LCRF, which is the Lung Cancer Research Foundation, to select and fund research projects to begin to address these unmet needs and concerns. To date, we have supported over $1 million worth of research that would not have occurred otherwise. So as you can see, a lot can be accomplished when patients work together and advocate for improvements in their own disease. Another partnership we have is with CEC Oncology, a company that focuses on continuing education for doctors, nurses, and other medical practitioners. This partnership allows us to focus on young investigators and encourage their contributions to lung cancer research. In 2018, CEC helped us secure a grant to hold a special think tank of EGFR thought leaders to discuss gaps in practice and research for EGFR lung cancer and ways to target these gaps. We had a number of prominent oncologists in the EGFR lung cancer field in attendance, and this really helped us zero in on our group's priorities. The EGFR Resistors Research Summit was one of the ideas that came out of the think tank back in 2018. We've held 4 EGFR Resistors Research Summits annually, 2 live and 2 virtual, to encourage young investigators to continue work in EGFR-positive lung cancer and collaborate.
Ivy was there as providing that critical patient research advocate input, and it was just always full of wisdom, Ivy. So next, I have the privilege of introducing Dr. Laura Petrillo. Dr. Petrillo is a colleague from Mass General in Boston, whom I hold in very high regard. Dr. Petrillo is a palliative care physician investigator in the Division of Palliative Care and Geriatrics, and she's an assistant professor of medicine at Harvard Medical School. She is a leading researcher and expert in the field of supportive care research for cancer survivors in the era of precision medicine. She's also the co-chair of the National Lung Cancer Roundtable Survivorship Task Group. So we are very fortunate to have Dr. Petrillo. She's going to talk to us today about symptom management and palliative care as relevant to lung cancers with targetable oncogenes. Dr. Petrillo?
Great. Thank you so much for having me, Dr. Lynn. It's wonderful to be here. I'm going to go ahead and share my screen, and if somebody could just make sure that, let me know that this is all working. Okay. Oops. All right. Okay. Let's see. Okay. I believe that I need to just quickly open my system preferences, and I apologize for that.
Dr. Petrillo, I can always share for you as well. I have your slides if necessary.
Thanks so much. Give me just one moment, and I think we should be able to get over this hump.
Great.
Thank you for your patience. Okay. Yeah, it may not be tenable to share my slides since the app says it needs to quit and restart in order to give the permission. I'm sorry about that. Maria, if you're able to share my slides, that would be very helpful.
Sure. Just tell me when to switch slides and I will go ahead and bring those up.
Terrific. Thank you so much. So as Dr. Lynn mentioned, I'm Dr. Laura Petrillo. I'm a palliative care physician at Mass General Hospital and an assistant professor at Harvard Medical School. And I'll be speaking about symptom management and palliative care today. Please advance. So as everyone here knows, we are in a wonderful new era of cancer treatment, which leads to improved survival. And so for the longest time, the main approach that we had for dealing with cancer was surgery. And at a certain point, radiation came along, and then in the last century, chemotherapy. And only within really the last few decades have we had these new treatments that completely revolutionized cancer treatment. So as everyone in this group knows, targeted therapy is a directed type of treatment that targets molecular alterations in cancer cells and more specifically controls cancer growth than chemotherapy. And I also have on this slide checkpoint inhibitors, which you may be aware of as treatment for lung cancer. Please advance, Maria. Great. So with these really exciting new treatments, the reason they're so exciting is because they improve survival, and that improved survival is reflected in the decreased cancer mortality that we've seen. So this is sort of the gold standard for measuring how there's been improvement. So these are some graphs showing cancer mortality in the US broken down by gender, and you can see that cancer mortality has decreased. Now, there are a number of reasons that this has happened in recent years. In part, it's because of cancer prevention measures like decreased smoking, but it's also because of better treatment. And we can see in this graph, there's males and females mortality, and you can see that lung cancer has really declined. And all of this improvement in mortality means that there are more survivors. So the graph on the right shows the cancer deaths that have been averted by better treatment and people living longer. So the red is what might have been, and the blue is the actual mortality rate. So just showing that many more people are living longer, and that means actually also living longer with advanced cancer in addition to early stage cancers that are being detected earlier. Next slide, please. As everyone in this group also knows, cancer-directed treatment and the effects of treatment on survival are only one piece of the puzzle. Individuals experiencing cancer and their families have so many different aspects of that experience that are important to them. Their symptoms, the side effects of treatment, their emotions that they experience, the effect of cancer on their relationships, and how they understand their illness and what to expect. Those are all really important parts of their experience. And that's the focus of my research, trying to understand what people's experience is with living with lung cancer and cancer, advanced cancer in general. And then also trying to design supportive care models that reflect this new reality of what people are living with advanced cancer in the precision oncology era. Next slide, please. Ivy mentioned Jill Feldman, and so this slide is Jill's. You may have all seen this slide. This is Jill talking about some of the challenges of long-term treatment and kind of the mismatch between how people might appear when they're receiving effective therapy and getting great scan results and not looking like they have cancer to everyone else. The top might somebody might look at someone dealing with cancer and say, she looks great. And that might be how their care team and people around them perceive that they feel. But then in the red are all the different things that an individual might be feeling as they're going through cancer and cancer treatment, and just underscoring that the tolerability of these treatments is relative and determined by the individual. Kind of that experience, the main source of truth is how someone is feeling as they're going through it, and only they get to sort of have that say. So many thanks to Jill for sharing this slide. Next slide, please. The other piece that relates to the patient experience of dealing with advanced cancer is that uncertainty is a constant. So we see these exciting survival curves. This is a Kaplan-Meier curve of Osimertanive versus another tyrosine kinase inhibitor, and showing that the survival is so much improved relative to what we used to have for treating lung cancer. These are kind of the survival curves and showing that people, they plateau, that don't hit the line of the x-axis, where people are living. The median survival in this study was 38 months, and in some cancer treatments and in some real-world groups, the survival with advanced lung cancer with targetable mutations can be even longer. But it's important to acknowledge that every kind of hash mark on this graph, every time the graph goes down a little bit, is one life lost to lung cancer. And so there are some people who will have a shorter experience of living with lung cancer, and there are some people who will have a longer experience. And so the only thing that's constant is change, right? Uncertainty is a constant for people who are living with lung cancer, advanced lung cancer, even with very successful, effective targeted therapies. And Maria, could you please advance the slide? I think this is a two-part. Yeah. So we've conducted a qualitative study with oncologists dealing who treat people living with advanced lung cancer, and also people who are living with lung cancer and their caregivers, just to learn what their experiences are of communicating about that uncertainty and living with it in dealing with advanced cancer with targetable mutations. And this is a quote from an MGH oncologist in talking about how they think about communicating what to expect from advanced lung cancer. And this oncologist said, "It's really hard to talk about the extremes when they're so varied. I've had patients who 10 or 15 years later are still responding. And for example, I have a patient who only responded for 8 months, and then things started to change right away and needed an emergent hospice referral." And I think it's just hard to prepare people for those huge extremes. Next slide, please. These are some more data from that study about people's experiences with communication about what to expect from lung cancer. Again, an oncologist mentions how excited they were when they learned that somebody had a targetable mutation, and that the main message that they're conveying is that the person will be able to live longer and have convenient pills. And then the message that's internalized by the patient is that this diagnosis of advanced lung cancer is not a death sentence. It's a long-term managed disease, and there's medications and treatments out there. The oncologist mentions that when the landscape is changing and shifting so quickly, everything could be different 3 months later because there's a new therapy doing very well. But this leaves people with a lot of questions. How long do I have is a question no doctor will really answer, but it's a question that a lot of people would love to have the answer to. One patient told me, and that experience was echoed by many people, although not all. Everybody sort of has a different preferences around the kind of information that they want. Next slide, please. We learned in that study also that people gain information from a variety of different sources in addition to their oncology team. Ivy had mentioned online forums and support groups that people join where they get support, but also get some really vital information. And sometimes the learning about the experiences of other people dealing with lung cancer was how people learned about what they might expect for themselves and get some more specific information, or at least examples of what other people had experienced. So one person said, it makes you painfully aware. Some people make it 15 months and some people are living 15 years. And another person talked about how they learned about their next potential therapy, a drug called lorlatinib. I think that's the next drug you go to. It has nasty side effects, but it keeps you alive. So just sometimes getting a preview even. So I think as a medical team, it's important for us to be, we, speaking as a clinician caring for for people with lung cancer, I think about these quotes often to say, the information that somebody gets from their oncology team isn't the sole source for everyone. Next slide, please. We also asked people about their experiences of living with uncertainty, and people told us how it was on their minds. One person said, "I haven't really found an answer of how not to think about living and dying every day. It's enjoying every moment, but in the back of your head, planning not to be there the next time this moment happens." And another person saying, "I'm too young to retire, but do I want to just work until I'm too sick and then be real sick and die? Or maybe work less and figure out how to live on a smaller paycheck?" These are incredibly hard decisions that people might be facing as they're in the process of adjusting to a new diagnosis. And so again, while that scan discussion might be very positive and the graphs are so positive and exciting, there are many different aspects of people's experience that I just want to acknowledge here when people are living with uncertainty, as hopefully resonates with some of you. And so then another person, this was a caregiver, talked about how life isn't the same after a cancer diagnosis, even though she's the one dealing with it. It's part of me that I feel has been lost in making that adjustment. Next slide, please. So in that same study, we talked with people about what they need for living well with advanced cancer. And one person in the study told us, I think there's a need for a more true integrative support system, not to say there's these resources available, but to say we view having a therapist or a social worker, having a team of people who see this duality of living well and also dealing with the future possibilities with lung cancer, because people are hurting. And even though they're doing fine medically, the doctors don't really address it. And so this led us to think that people are interested in support for coping with uncertainty. People also talked about hoping for connection to their peers and for ways that they could adjust their lifestyle to be dealing with longer trajectories of cancer and find ways to take control, like through nutrition and exercise. And people also in our study expressed interest in educational resources to be able to understand their cancer and what to expect and know about the possibilities of what might be coming down the pike in terms of clinical trials and new options. Next slide, please. So this leads to my next question is, how do we think about the types of support that are possible for people who are in this space of living with advanced cancer? And I want to just take a moment to talk about what palliative care is, since this is my area of focus. So palliative care is a specialized type of medical care that's for people living with a serious illness, and it's appropriate at any age and any stage of illness. And it's focused on providing relief from symptoms and stress of the illness, and the goal is to improve quality of life for both the patient and family. And on the right of this slide in the blue circle are some of the things that we in palliative care focus on: symptom management, psychosocial support, supporting people's understanding of their illness and making decisions, and then thinking about the future and kind of their preferences about their care, thinking about the spiritual and cultural aspects of care, and supporting people in any decisions they might need to make. Next slide, please. One thing I really want to emphasize, though, that may be a perception that people have, is that palliative care is not end-of-life care, or I should say it's not exclusively end-of-life care. Palliative care originally kind of grew up as symptom-focused care for people who are close to the end of life, and has expanded in recent years to be a focus on quality of life that's appropriate at any stage, at any age, kind of throughout the process of dealing with illness. This kind of shows the outdated idea of, you could focus on quantity of time and focus on fighting the cancer, and then at a certain point you totally shift gears to focusing on quality of life. And so that kind of quality versus quantity question kind of was the old idea, but the new idea about thinking about quality of life focused care is thinking about layering a focus of quality of life on top of the things that we do for disease modifying care to extend length of life. And so thinking about quality and quantity. And I include in this that, the palliative care is shown here in this light blue and kind of showing that it wiggles. Like sometimes you need a little bit more palliative care. Sometimes you can focus less on palliative care. And that as people's health changes, the amount of palliative care that somebody needs might increase. And it's included in here that hospice care is a part of palliative care, because it's true, part of my training as a palliative care doctor is in hospice care. And that's when quality of life focused care is the main and exclusive focus of care, when there aren't any options for using cancer-directed care. And, I'm trying out a new analogy, so you'll have to let me know how this works. But I was thinking about this in terms of, saying that palliative care and hospice care are not synonyms. They're only synonyms so much as the whole alphabet and the letter Z are synonyms. So the letter Z is part of the alphabet, but it's the very end. There's all those letters A through Y that are important. And so I think about palliative care being appropriate for so many more people than who are currently accessing it right now. Next slide, please. And the way that we know this, the way that we know that palliative care can be helpful for people throughout the course of dealing with advanced cancer, is from some studies that really gave us excellent evidence to demonstrate that early integration of palliative care helps people. There was a randomized control trial here at Mass General conducted by Jennifer Temmel and colleagues in the clinic where I practice that showed that integrating a focus on palliative care, on quality of life from the time of diagnosis, helped people with improved quality of life. It helped them with improving their mood and their understanding of what to expect from their illness. It decreased the use of non-beneficial treatments like being in the ICU at the very last moments or dying in the hospital. And what was a surprise to everyone, like I mentioned before, we used to have this kind of binary idea of quality versus quantity. So they looked at kind of how the effect was on quantity of life to make sure that it didn't shorten people's lives to focus on quality. And people actually lived longer when they were receiving kind of quality of life focused care. That wasn't the purpose of the study. The purpose of the study was to look at quality of life, but this definitely raised eyebrows and helped launch a lot of palliative care programs just to show that this helps people and doesn't take away from the cancer-directed treatment to focus on quality of life. Next slide, please. This is just a story from a person who received palliative care, and just emphasizing again that moving attention to quality of life upstream in the course of somebody's time with cancer helps them live well, as opposed to thinking about dying well with cancer. So this person talks about how neuropathy affected their hands and their feet, and their hands are how they made their money, and being in pain, they shut themselves out and were staying in their room. But then they felt in control in the driver's seat when they were talking with the palliative care team and focusing on their symptoms, and they felt more empowered as they went through their cancer treatment. So that's just one example that I like about living well and dealing with symptoms. Next slide, please. And this is another analogy. You might see this one. It's about palliative care as the umbrella, and kind of the older idea of adding palliative care late in someone's course is like saying, okay, we're focusing on fighting the cancer, or focusing on these things. And then suddenly it rains. Somebody chases after with an umbrella. Here, this will help. Thanks. So we wish we'd had this earlier. That's on the top row. And on the bottom row is the idea of early palliative care, thinking, here's an umbrella. You might not need this yet, but just in case. And then when someone's caught in a rain, they can just pop open their umbrella and they say, so glad we had this when we needed it. So that's the idea of just integrating that focus on quality of life. Sometimes it's dealing with symptoms that are happening right now, and sometimes it's anticipating things that might change, or at least having a quick connection if somebody is experiencing a change in their health. Next slide, please. One of the reasons I love palliative care is because I feel like when it's done well, it can address some of the broken aspects of healthcare. And for me, this is that holistic aspect of thinking about the whole person that can get lost sometimes in medicine. I think I definitely, in saying this, don't mean to disparage any of our oncology colleagues, because oncologists are amazing and definitely think about their patients as whole people without a doubt. And there are time constraints, there are focus kind of constraints that I think thinking about team management of people who are dealing with cancer and their families is really the how we achieve the best care for people. Next slide, please. And so I just want to share this last idea that in talking with people about their needs in living with advanced cancer, we really learned that in addition to some of the things that I mentioned, like symptom management, psychosocial support, and understanding their illness that are appropriate for palliative care, what we started to hear about in this group of advanced cancer survivors who are living longer with advanced cancer, that really some of their needs resemble what we now call survivorship care, which is a very heterogeneous kind of term that encompasses the care that's focused on people who have survived cancer in general. And so generally speaking, survivorship care has been conceptualized as care that's appropriate for people with early stage cancer who've completed definitive therapy and then are kind of looking at cancer as in the rear view mirror and trying to kind of return to their lives. And for people with advanced cancer, cancer may never be in the rear view. It may be always part of their lives, but some of these survivorship aspects of how do I do care coordination? How do I think about health promotion and living well? How do I think about healthy behaviors and lifestyles to be in it for the long haul and take the most control of my treatment and experience. And so we're starting to think more about how to blend survivorship care and palliative care for the advanced cancer survivors that are emerging in this exciting new time. And I think of that as just really good patient-centered care. Next slide, please. Happy to take your questions and excited to share the panel with Ivy. And I just want to say thank you to all the patients and caregivers who are in our studies and the clinicians, my research mentors, Jennifer Temmel and Joseph Greer, and all of my research mentors and collaborators and research coordinators. Thanks.
Great, and thank you, Dr. Petrillo, for an amazing talk. I'd like to invite back all our panelists, including Dr. Petrillo, for some discussion and a Q&A from our audience, if that's okay. If we can ask if Ivy can join us again, that'd be great. Wonderful. While she's joining, thank you. Great. Listening to both your talks, I'm just struck by how much progress we need to make on the last mile, really helping patients get their care delivery. And I just wanted to throw out an initial question for food for thought. And what are some of the areas that we as a field should be making the biggest investments in to really move the needle to benefit of our patients? I think you alluded to a couple, but I'd love to hear just a discussion back and forth amongst you two on kind of both sides of the coin on where we can make the most impact.
I think anything that fosters, I'm talking about kind of the communication side right now, anything that would foster communication and understanding between patients and the healthcare providers could be really helpful. I kind of alluded to it a little bit during my talk that, when someone is newly diagnosed, all of a sudden, you have all this new language and it's hard to understand what these things mean. What is this scan? What is this clinical trial? What is, this informed consent that someone's showing to me? I don't know, people don't know all the terminology. So, the efforts that are starting to be made to create more lay descriptions of trials and more lay descriptions, plain language descriptions of treatments, I think is very important and could go a long way to helping people. Because if people aren't informed and don't understand what's being asked of them to join and participate in, they're just going to get scared and say no. That's just, common, human response. So I think that's a really important area right now.
Thanks so much, Ivy. Great answer. And I think it's hard to choose just one thing of what is most important right now in cancer care delivery. My strongest feeling is that we need to make sure that everyone who's eligible for these optimal treatments is receiving them. And so I have a strong feeling about the need for improved access for universal biomarker testing and just getting people to the right treatments. And I actually was really impressed in some of our research. I'm always continually impressed by the kind of self-organization of people into advocacy groups and the sharing of information. I've learned about people helping each other find clinical trials and find the right treatment. And so I think that that's a really powerful thing, but I also think it's on us in the healthcare system to ensure that the equitable care is happening. So I would say if I had a magic wand, that would be my number one priority. But in terms of the supportive care of people who are living with advanced cancer, we need so much. There's a bill right now in Congress about the Survivorship Care Act, about improving reimbursement for supportive care and survivorship care. It's a little bit focused on early stage cancer, and I think that lung cancer groups could be advocating for the inclusion of advanced cancer survivorship in that, because a lot of the services that people receive for survivorship care or palliative care, honestly, a lot of the supportive care services that people receive are sort of ad hoc. It's what is available at the hospital systems where they are. It's what people, squeaky wheels have the ability to advocate for, or what a particular, the luck of being assigned to a particular clinician who believes in some of these things as to whether people get kind of access to some of these things. So I would say access maybe is the theme here. But in my ideal world, everybody would have access to ideal cancer treatment. And then once everyone knows what their, optimal cancer treatment is, they would automatically have an assessment for the types of supportive care that they need. And it's not going to be the same for everyone. Some people are going to need nutrition support. Some people want help with physical activity. Some people want help with this kind of coping with uncertainty or a group support. Some people want kind of more kind of social support. There's a whole variety of things that people might need help with. But I think providing a minimum level of care across the board to every single individual is should be where we're aiming, and then have the ability to layer on additional support. And I don't think we're anywhere close to that, despite kind of guidelines and recommendations. I think we know what the gold standard is, but the implementation isn't close to there.
And I just want to add on, I completely agree with Laura about the access issues, biomarker testing access issues. And I wanted to add to something that she mentioned that I thought is really important, how she said some people might need this and some people might need that. Well, I think it's also important just not to assume what patients need and to ask them, because, you know, we're all different. We're all, you know, people, we're all different. Some of us might want support in one area, some of us might not. And, you know, without having that conversation up front about what, you know, your goals are and what's important to you, and getting to know the patient a little bit individually, you know, you just can't, you know, just make a blanket decision on how they could be treated. So it's important to try to, you know, individualize that as much as possible.
Thank you. This is an important topic, and I feel like we could spend an entire day talking about this. I just, as a follow-up to both of your answers, I would love to hear from your perspective. What do you think are the biggest gaps or most urgent areas of need in terms of improving on that patient-centered approach to designing clinical trials and research that's going on right now?
You know, I mean, it would be great if there was an easy way to access clinical trial information. I mean, I know that's talked about a lot, but it seems like, you know, a lot of it is just very ad hoc. You know, if you happen to be, you know, someone who joins an advocacy group, you know, geared towards your type of lung cancer, you can get that information. If you happen to be at certain hospitals with certain clinicians, you can get that information. But otherwise, it's just really difficult. And this goes back to the whole, you know, access issue, only now I'm talking about, you know, clinical trial diversity as opposed to biomarkers. I mean, how do we get, you know, that clinical trial information of what's available out to everyone and people in the community, and, you know, in an understandable way? And, you know, clinicaltrials.gov isn't really that. And even if you can figure out things through that, it's hard, it's not real time. So by the time you try to get, you know, information about a specific arm of a trial, it might already be closed, you know, at least for the cohort you need to try to join. So it just needs to be simplified as much as possible. And, you know, I mean, I have to tell you, there are people in our group, in the EGFR resistors group, who would love to join clinical trials. And I hear more often that, you know, someone wanted to be in a clinical trial and was, you know, ended up either being deemed not eligible, or the trial arm closed, or, you know, something happened where they couldn't get in it, than hearing someone who doesn't want to be part of a clinical trial at all. So, you know, there has to be some way to kind of match that up, because, you know, there's really motivated patients who want to try these new drugs. And then there's, you know, all the investigators who want to get their clinical trials accrued, but somehow that's not lining up. So that's something that we really need to work on improving.
Thanks. And I'll add to, in thinking about clinical trials and priorities, there's kind of the mention, Ivy's whole talk about including research advocates and including the patient perspective in clinical trial design is critical. I think just historically, the way that clinical trials have been designed is to show drug efficacy without, it's like, makes sense. It's logical. That's how, that's the primary input. And I think we can do better. We can include patient perspectives on what are the most important outcomes to people who are living with cancer. And I think, we're moving in that direction by including more kind of PRO assessment. And I think there have been exciting advances in kind of making clinical trial delivery more patient-centered and bringing it to patients. And that happened as a function of the pandemic and maybe are shifting a little bit. But even things like inclusion criteria, making them be so that they reflect a more real-world population, all of these things, like a shift from thinking about kind of how to get the drug approved and prove its efficacy to how to enhance and improve the lives of people and kind of what's important to them and how to make it accessible to people to participate so that then that information can translate into the care of everyone living with cancer. And so I would say that would be the priority, is having a patient-centered view kind of throughout the whole spectrum of drug development, and because that then affects clinical practice.
Dr. Patel, your microphone.
Yeah, you're muted.
Jess, let's have you move forward while Dr. Patel works on his tech issues, and I'll help him out.
Great. So I would love to hear from you, Dr. Petrillo. I know you've done a lot of work on developing supportive care studies, and personal experience working with patient research advocates. And would you be able to share with us how you've integrated the input from patient research advocates into your own research, and how that could potentially be extended to other studies that are going on in lung cancer space?
Great, absolutely. I want to echo Ivy again and just say that kind of integration of research advocates kind of throughout the process is critical. So I think, not just thinking about, I think in my research is pretty clear how the connection to integrating patients, since I'm focused on kind of supportive care, it would be really insane not to include patient perspectives on what is the right supportive care. So it's very obvious for my type of research, but I think for kind of basic science research or translational research, it might be harder to think about when and how. But I think the answer is kind of all along the way to think about including research advocates. And I love that great agencies are starting to think about including patient advocates in research design, just to think about, again, what are the outcomes that are important to people? How do you make sure that the way that you're explaining your work makes sense to everyone and is relevant and important to everyone? So personally, I've had the real incredible good fortune to work with Jill Feldman really closely. And I've worked with Ivy before and worked with other advocates just on kind of how to design research that is important to people. And for me, that was kind of in the grants process, sharing my specific aims page, and then kind of saying, oh, I think we need to do a stakeholder phase, and making sure that we're selecting stakeholders that represent, different perspectives, and then thinking about ways to deliver and then disseminate the message. I mean, all along the path of the research, there are roles and important and critical roles for advocates. So that's been in some of my projects. And then also in the Lung Cancer Roundtable, I've been also really fortunate to get to work with advocates. And again, the voice of people with the lived experience is irreplaceable. It's foundational. And so I really support this kind of way that science is moving. And I think it's the best way to do research. And I just hope that the scientific community finds ways to find representative voices, to honor the patient voice, and to also respect kind of the motivations that people have for participating in research. So I think that it's hard to separate kind of out those motivations. And so making sure that we are truly valuing the precious time that people give us, and seeking out the voices of people who might not find their way to advocating. And so I think that that's something that we can kind of think about a more kind of universal approach to as well, both for the academic community, but also for pharmaceutical companies who strive to include patients in their research.
Great points. Hopefully round two, my audio works. We got a question from the audience. Are lung research groups making folks aware, and if so, how, on radon exposure in lung cancer and never smokers. I've not heard, the patient says, I've not heard this brought up with my oncologist. I tested my mother's house. She had elevated levels. I had a company install a system. I guess maybe let me broaden that. And what are things we can do in the advocacy and academic communities to advocate for prevention along this axis?
Yeah, that's a really very important topic. And there is actually an advocate, I'm quickly looking her up, who has gone through the STARS program of training as a research advocate. Her name's Jacqueline Nixon, but she runs a group that, really focuses on radon abatement and radon awareness as a cause of lung cancer. And I will look that up and put that in the chat. But we are trying to get out there, all the potential causes or possible causes of lung cancer. And we are making more strides. I mean, there was a, very limited view of what causes lung cancer, 20 years ago, that, it was only due if you had some form of tobacco exposure. And now we have more information. We're learning about radon. We're learning about the potential impacts of air pollution. We're learning about, is there a family history link? And there is research going on in a lot of these areas. I know the larger nonprofit groups also, like Longevity or GoTo or LCRF, are definitely telling people about the potential dangers of radon. And in many places, you have to check with your, where you live, but in many states, I believe you can even apply to get a free radon kit to test your house. But that's, I think something that's handled at this point on a more local level. But I think I have to look up the name of the group. I think it's called Citizens Against Radon. I can't remember exactly what it's called, but I'll look it up and I'll put it in the chat. There's definitely work being done in that area.
No, thank you for that. And this question may be more for Dr. Petrillo. Could you repeat or expand on your comparison about the differences between palliative versus hospice care?
Absolutely. So our field, palliative care, it did kind of grow up in the space of providing excellent symptom management, so pain management and all kinds of symptom management for people who are approaching the end of life. And so there is kind of a lingering perception that those two things are equivalent. But palliative care is a kind of broad umbrella of types of care that are focused on quality of life. And so in recent years, we sort of have come to realize in about the past 2 decades or so that integrating that focus on quality of life throughout the course of dealing with serious illness like cancer or other serious illness improves quality of life. So adding that focus helps people feel well, live longer sometimes, and live better and have their families have a better experience. And so the idea that palliative care is the equivalent of end-of-life care is really outdated. Palliative care is kind of symptom-focused, quality of life-focused care that's for people and their families and dealing with the symptoms and the stress of serious illness. You will definitely still find people who are confused about that. We've been doing a lot of studies to try and understand public perception, how to message palliative care. I think once people access palliative care, they have a sense of how it can help them. And I would say very, very commonly, people say, man, I wish I had this sooner. In fact, I had a patient and their family yesterday in my office really mad. Like, how come I'm seeing you now? I wish I had seen you last year, like 2 years ago, like this would have been so helpful. And where can I get a megaphone to just file a complaint? They literally wanted the hospital number to file a complaint because they hadn't gotten access. So it's always a common thing to say, like, I didn't know that this was what this was. I had a perception of what this was. And I will say it is delivered differently in different places. But in general, palliative care is this quality of life focused care. And it's something you can always ask for. There's a website called getpalliativecare.org, which I'll put in the chat. And so people can look for palliative care clinics clinicians that are in their communities. Palliative care is delivered in offices, just like oncology care. It's delivered in the hospital. It's delivered in kind of home-based organizations. And so this directory can help people find palliative care. And so people need to be referred by their medical teams. And so again, it doesn't always happen. So if somebody feels like adding a focus on kind of symptom management or quality of life would help them, they can always ask for it. Thanks for the question.
That's wonderful, Dr. Petrillo. And you
how early integration of palliative care is so important for patients with lung cancer.
And you're kind of getting into this. I sometimes see patients who want to get palliative care in their community. They might live away from Boston and not able to come to Mass General kind of routinely for supportive care. And especially after the pandemic, I've heard from some patients that there can be extremely long wait lists, or the couple palliative care physicians that used to be in their community have now moved on to another area. In medical oncology, we often have patients come for consultations or second opinions. Is palliative care an area where it is worth patients seeking second opinions or consultations, even at distant locations? Or how would you advise patients and caregivers manage situations like this? And maybe, Ivy, you have some insights on this as well from your interactions with the EGFR resistors community too.
It's such a great question. So there is kind of a growing area of telehealth palliative care that is available. And sometimes it's not always symptom focused. It might be kind of around that kind of care coordination, illness understanding, planning for the future piece. But there are some kind of providers that are getting into that space. So that's one possibility. I will say for the type of palliative care that I provide, we usually do sort of require that someone, if they're coming for a second opinion, for example, at MGH, we'll see people for a second opinion for palliative care too, or to provide a kind of one-time consultation. But then to kind of provide that ongoing care, it's usually a team focus kind of in collaboration with oncology. So we don't usually provide, although I certainly have provided palliative care when someone is getting their main oncology care elsewhere. And unfortunately, it's something that opened up a lot. Like we had more kind of telehealth palliative care possible in the times when kind of the licensing and kind of state borders in the US at least were relaxed. And then it's sort of tightening back up again around that. But I think it's an area of need. And I would say think creatively too, because there are home-based organizations that might provide palliative care. Sometimes even it's hospice agencies, not to confuse things anymore. I've spent all this time telling you that hospice and palliative care aren't the same, but then there are these hospice agencies that are sort of wading into the palliative care space to have home care providers that provide that perspective. Sometimes insurance companies will actually provide consultations that may be staffed by different types of disciplines that provide some palliative care. And I would say too, like thinking broadly about palliative care, it doesn't have to be a board certified palliative care clinician that provides palliative care. There have been studies of kind of lay navigators that provide pieces of this palliative care idea. And then in our medical system, and I know this is happening across the US and likely in other countries as well, we are trying to emphasize primary palliative care, meaning palliative care skills that are kind of disseminated across clinicians who are providing the direct kind of serious illness care. And this is true in cancer, but then in also other serious illnesses as well. And so that is kind of communication training to make sure that there is kind of communication around kind of goals and values and illness understanding kind of throughout the course of somebody's illness and upfront when somebody's hospitalized. So that's a kind of primary palliative care that we're trying to make sure that all clinicians who deal with people who are living with life-limiting illnesses or advanced illnesses, those kind of skills is, I think, an emphasis of our field because there is a workforce shortage. There is a shortage. There's also perceptions and stigma that limits access. So these are all the types of approaches that we're using to try and increase access to palliative care. And I'll say too that family that was really annoyed with me, we went through all of the symptoms that the person had and we talked about things. And I said, you know what? You've actually gotten great primary palliative care from the nurse practitioner on your team. Like you have been getting palliative care. You haven't been getting specialty palliative care, but I think it's important to acknowledge that it doesn't require a palliative care specialist necessarily, but the emphasis is on, how do we maximize quality of life? And that can take different shapes and needs to take different shapes for different people.
No, great answer. There's a question, should there be any concern occasional nearness to campfires, and I'll just take that one. I think, anything in moderation where you're not inhaling anything, A, either long-term, or B, that has carcinogenic risk, which, campfires typically are wood, things like that. You typically are okay. There is some data, though, given, things going on with climate change, that these longer-term exposures to fumes may or may not actually have carcinogenic risk. There are some preclinical models that have shown that a longer term exposure. So I think, you're grilling outside every once in a while. You're in a campfire. That's probably fine. You always want to have good ventilation. But even some of the data around stoves and combustion are somewhat concerning. And so I guess, like most things, in moderation with good ventilation can avoid those issues. There is a question about, and I would love to get both your thoughts on this, and how do you integrate palliative care services and avoid fragmentation? One of the things that often happens for an oncology patient, and Ivy, please comment on this, is everyone is kind of really in a narrow lane of expertise. And sometimes it can feel like you're playing telephone a bit, and you have to be your own advocate. And so, we definitely want to add the best members for the team, but maybe I could ask Ivy and then Dr. P your thoughts on how to best navigate this when there are many moving pieces, many balls being juggled simultaneously.
Yeah, I mean, I think it's very helpful if you have someone who can kind of help with that. I mean, many oncology offices have, an oncology nurse or a nurse navigator who, you can go to and have help coordinate this information. If where you're located, you don't have access to that, maybe you have a caregiver, and it doesn't have to necessarily be, someone you live with. It could even be, it could be a friend, it could be an other relative who has the time to help you kind of coordinate some of this information. And some people, can coordinate it themselves also. I mean, that's one of the wonderful things about some of these medications that we're taking, some of these targeted medications, is, the side effect profile is not always, that significant. And as a result, a lot of us are feeling better day to day, and we can coordinate a lot of these things on our own. But I do, even from personal experience, have to admit that it is complicated, especially when you're going to several different doctors, and different doctors are prescribing different things. You have your main doctor providing your cancer prescriptions, then you might have someone, and as Laura said, it might not necessarily be a typical palliative care doctor. It might be a dermatologist, or you might have a psychiatrist you're going to, and you're getting all these different prescriptions. And one thing that is really important to kind of keep in your mind are drug interactions. And especially if you're seeing a lot of different practitioners, sometimes you really have to be your own advocate to make sure everyone knows everything else that you're taking, and, to make sure that, nothing is causing, a combined impact that's detrimental to you. So sometimes you really have to be your own advocate for those types of things.
Yeah, I agree about that. And I also think it's unfortunate. Like, I think if we could go back to the magic wand portion of the Q&A and say, like, what would we change? Like, I wish we had a more integrated health system across the board where people had, a single electronic health record, and clinicians could always see, the experiences someone's had and the medications they've been prescribed. For us in palliative care, we have a new system within the past, 5 or 10 years in my state of being able to see the opioids that have been prescribed in various places. And I wish I had that for all medications, just to see what people are getting from all these different places, to know exactly. But I think the onus, I agree that at the moment the onus is on people and their families, but the onus should be on the medical team to be keeping track and being in touch with each other. And that's part of the reason I think there was a question earlier about kind of receiving palliative care potentially in one place and oncology care another, or kind of how do you think about that? And that's one of the reasons that we have a pretty strong emphasis on trying to keep those things combined. And so yet another reason why I think all places should have some minimum type of supportive care in whatever shape it takes. But I think it is a risk to add additional kind of members to someone's team, but something that should be on us to sort of, if we're prescribing, making sure that we're prescribing safely and that we're in communication and coordination with each other.
Thank you. We have time for one more question. I'll tie together two questions from the audience. It actually stems from the last comment, Dr. Petrillo, that you were making, and it's a question for both of you. Very curious about how to deal with fatigue, which is a common side effect with a lot of targeted therapies. The question reads, I often read about methylphenidate being prescribed. Could you tell us about some safety and reasoning behind this prescription? How effective is it? And then there's also optimal pain control techniques and why sometimes additional medication might be needed to help with breakthrough pain.
Sure, I'm happy to start with that. We don't have great evidence-based approaches to fatigue. There are some good things in being studied about kind of behavioral approaches, and behavioral approaches is usually one of the first things that we talk about with people. So thinking about how to conserve energy, how to use your energy, prioritize during the times of day that feel like the right times, and then troubleshooting around nighttime sleep, around nutrition, around things that might contribute to energy is usually my first approach. We do use medications, the stimulant medications. The data are sort of mixed about effects on fatigue, but anecdotally, I've had some people really respond, some people don't notice a difference, and some people get kind of some anxiety that's triggered by those medications. So the things that we have to think about as risks for stimulant medications are histories of arrhythmia, and then also a history of anxiety, just knowing that it can make it worse for people. Sometimes we will just try, and then sometimes the risk-benefit balance of the arrhythmia risk is, in favor of trying if somebody has really low energy and wants to try something for fatigue. The other thing that we think about sometimes in certain select situations is steroids. People may notice a boost in energy on the days that they're getting steroids when they're getting chemo, for example, and we take advantage of that. And sometimes we'll use selectively steroids, again, something with a ton of side effects, so something we're very careful about. It's a risk-benefit balance consideration. But methylphenidate is something I use from time to time with patients for energy. But certainly I think about all of those behavioral things first, like ways to maximize energy. I didn't mention exercise, and I think it's really critically important to think about increasing physical activity. It's kind of counterintuitive. People think about exercising and becoming more tired, but exercise improves people's conditioning and kind of being active. And being active doesn't have to mean, running 30 minutes a day or doing the Stairmaster. It can mean walking around the house. It can mean taking a walk down to the mailbox or down to the end of the street. Kind of just getting more activity is a really important thing. And I think, one thing that I'm trying to think about as a clinician is how to balance, because I know sometimes it feels like a lecture, or it feels hard to hear, like, you should exercise more. And I think just finding ways to feel like that is an achievable thing that somebody could integrate. It's really, really important. I think it's really important for a whole host of health reasons. So those are my approaches to fatigue. I know there was another part of the question about pain management and how we think about pain management. There's not a short answer about this, but I think for pain management, we always are thinking about, my personal approach is always thinking about, how does pain affect somebody's ability to function? And then we treat and manage pain to maximize someone's function. So we're thinking about using kind of the lowest risk medications first, and thinking about medications like over-the-counter medications. They're not always without risk. As everybody hopefully knows, ibuprofen and Tylenol in certain situations can have risks, but those are sort of our kind of first line approaches to things. And then we have escalating types of medications for escalating amounts of pain. And we also have selective types of medications, like medications that help with nerve pain, for example. inflammatory pain, in addition to the strong pain medicines like opioids that we use in certain situations for cancer-related pain. But I will say the main kind of philosophy is around treating to function. So I'm not treating usually to a number on a pain scale. I'm treating to helping somebody function and do the things that they enjoy in their lives. So I think that we're in a really interesting moment historically in terms of opioids and how they're used in cancer care in light of the opioid crisis that's happening kind of worldwide. And I think it's an important conversation to have on an individual basis with the clinician who might be prescribing as to when and how opioids could be appropriate. But I think there's absolutely a role for them for cancer-related pain. And I will say too, I use the least amount possible and help people taper off when they don't need them anymore.
Well, I don't have anything specifically to add about the medicine because, obviously I'm not a medical practitioner, but I do want to mention that I think it's really important to listen to your body and to ask for help when you need it. Every day you might not feel 100% every single day, but that's okay. There might be some days that you need to rest a little bit more, or if something is coming up, you might need to just make it easier, or have somebody help you with things so that you can save up your energy for, an event that's, coming up that's really important to you. So yes, definitely reach out to your healthcare providers for a medical intervention for, pain and fatigue, but also just think about, none of us, really want to change our lifestyles, based on lung cancer or any other disease, but you might have to just think about like kind of moderating things a little bit and saving big projects for days where you feel better and feel like you have tons of energy, and on other days just take it a little bit easier and ask for help and take care of yourself.
Absolutely. Wise words to end our session. Really want to thank Ivy and Dr. Petrillo for joining us. And with that, actually wanted to thank all our speakers, our audience. Want to thank my co-chair, Dr. Lin. Want to thank our sponsors, Janssen, Lilly, Takeda, Genentech, Exact Sciences, GE Healthcare, BMS, and Mirati for sponsoring this event. I want to thank the Grace team for putting this wonderful program together. And with that, wish everyone a wonderful rest of their weekend and hope to see folks at similar meetings in the future. Thank you.